So, Assalamu alaikum. Greetings, my dear doctors, and welcome everyone to our past paper course. And we will begin the second session on our October 2020 diet. So, doctor, please read the questions.
Okay, what is the most appropriate initial intervention in this patient? Albendazole, fluconazole, itraconazole, metronidazole, or tinidazole? A 45-year-old presents to the gastroenterology clinic for review. He has been experiencing vague abdominal pain affecting his right upper quadrant, nausea, some gradual weight loss, and intermittent fevers over the past few months. He is a sheep farmer. He takes no regular medication and is otherwise well. On examination, he is aparaxial. His blood pressure is 121/82, while his pulse is 70 beats per minute and regular. There is vague tenderness in his upper right quadrant on palpation of the abdomen, and you can feel a liver edge. Investigations are hemoglobin is 123, white cell count is 10.9, and platelets is 162, sodium 144, potassium 4.5, creatinine is 85. ALP is C-reactive protein is 122, ALP is 281, 287, and ALT is 122. Both are raised. Bilirubin is 17, and echinococcus serology is positive. Hepatic ultrasound scan shows one cyst 5 centimeter in diameter, a smaller daughter cyst of 2.5 centimeter in diameter. What is the most appropriate initial intervention in this patient?
So, can you tell me the diagnosis from this scenario?
Mm,
So, this patient has come up with the features of right upper quadrant pain with hepatomegaly, and there is significant elevation in the transaminase, as well as the alkaline phosphatase level is significantly elevated here. So up to this point, this indicates some sorts of hepatic disease. And if we go further, the echinococcus serology is positive, and the hepatic ultrasound is showing the daughter cyst. So hepatic disease plus daughter cyst plus echinococcus serology positivity points towards the echinococcus granulosis, which is also known as the hydatid disease. So what should be the choice of treatment in case of hydatid disease?
albendazole?
Yes, very good. Either albendazole or the mebendazole. Albendazole or mebendazole are the choice of treatment in case of hydatid disease, which is also known as the echinococcus granulosis. So can you tell me the mode of action of albendazole or mebendazole?
It inhibits the tubular
Yes, very good.
tube,
So albendazole, mebendazole, as well as the colchicine, all the three drugs causes inhibition of the tubulin polymerization. This patient is suffering from hydatid disease, potentially due to his job as a sheep farmer, where he is likely to have been exposed to echinococcus. The constellation of right upper quadrant abdominal pain, hepatomegaly, nausea, and weight loss indicates liver involvement, which tends only to occur when cysts are over 10 centimeter in size. The cyst seen on the ultrasound scan, coupled with abnormal liver function test, confirms the diagnosis. Infection can persist for many years before presentation. Albendazole is the chemotherapeutic intervention of choice. Mebendazole can be tried if albendazole isn't available or tolerated. Both drugs are available on a named patient basis in the UK. And fluconazole is the antifungal drug, as well as the itraconazole. They have no role in hydatid disease, as well as the metronidazole or the tenidazole. Metronidazole or tenidazole, they are usually the choice of treatment in case of antiprotozoal disease like the giardiasis or the amebiosis. Okay, next question.
sorry.
Yes, go.
What is the most appropriate intervention? Cholestyramine, cyclosporin, methotrexate, prednisolone. or ursodeoxycholic acid. A 52-year-old woman comes to the hepatology clinic complaining of lethargy, gradual weight loss, and persistent itching. She has mild hypertension for which she takes 5 milligrams of enalapril. On examination, her blood pressure is 110 by 80. Her pulse is 75 regular, and she has xanthelasmas, multiple spider nevi, and scratch marks over the abdomen. There is one finger breadth hepatomegaly. Investigations are hemoglobin 101. WBC is 12.7, platelets are 115, sodium is 143, potassium is 5, creatinine is 115, and ALT is 231, ALP is 381, bilirubin is 23, and antimitochondrial antibody is positive. What is the most appropriate intervention?
So what may be the diagnosis here? So PBC, primary biliary cirrhosis, this is the AMMA disease. AMMA disease means Middle-aged mom with AMA positivity, and there should be elevated transaminase as well as elevated in the alkaline phosphatase. So this is the case of primary biliary cirrhosis, and patient often comes up with the features of itching and pruritus. And in case of and here they have not mentioned regarding the duration here, but in case of patient with early primary biliary cirrhosis, when they present with itching or pruritus, we usually go with the ursodeoxycholic acid. Ursodeoxycholic acid is the first line choice of drug for the management of itching and pruritus in case of either early PBC or early PSC. And obeticholic acid can be used as an alternative. And in case of advanced cases, we should go with the cholesterol. So the most appropriate intervention here should be the ursodeoxycholic acid. The most likely diagnosis in a patient with lethargy, itching, raised ALP, and positive anti-mitochondrial antibodies is primary biliary cirrhosis. Ursodeoxycholic acid is the intervention of choice. If it is tolerated, if it is not tolerated, then obeticholic acid is the potential second-line therapy. Patient with PBC often has coexisting hypercholesterolemia, which fits with the xanthelasma. So here patient also has the features of xanthelasma. Most probably patient has the underlying hypercholesterolemia as well. Although data from the Cochrane meta-analysis did not confirm a benefit of liver outcome, it is thought to be because of relatively late use of compound. And cholestyramine is usually reserved for the advanced cases, and cholestyramine is also indicated in case of bowel resection-induced bile acid diarrhea. So just for the shortcut, remember middle-aged mom with AMA positivity and elevated transaminase and ALP points towards the primary biliary cirrhosis.
What is the most likely findings on the skin biopsy of this patient? Basal keratinocytes proliferation, neutrophil and lymphocyte infiltration, or granular immunoglobulin A IgA deposits in the dermal papillae of the perileonal skin, or immunoglobulin IgG deposition throughout the epidermis, or linear IgG deposition at the dermoepidermal junction, or linear immunoglobulin M IgM deposition at the dermal epidermal junction. A 23-year-old woman presents to the dermatology clinic to undergo a biopsy of a rash which affects her arms, legs, and body. The rash demonstrates multiple flaccid blisters. There are also multiple ulcers within the patient's mouth. A diagnosis of pemphigus is suspected. What is the most likely finding on the skin biopsy of the patient?
So what should be the skin biopsy findings in case of pemphigus vulgaris? So let's
IgA deposition in the dermal papilla of the perileonal skin.
no granular IgA deposition on the dermal papilla of the perilesional skin. This is seen in case of dermatitis herpetiformis, which is associated with
Okay.
celiac disease. And basal keratinocyte proliferation, neutrophil lymphocyte infiltration. This is seen in case of classical plaque type of psoriasis. And
Linear
IG,
immunoglobulin G deposition at dermal junction.
Which one? C or D?
D.
Linear IgG deposition at the dermal epidermal junction. Okay. So pemphigus is the most superficial one, and pemphigoid is a deeper compared to pemphigoid. So let me show you. So pemphigus is the most superficial one, and pemphigoid is just a deeper one. So in case of pemphigus vulgaris, the antibodies would be detected against the epidermis. And in case of bullous pemphigoid, the antibody would be detected in case of dermo-epidermal junction. And plaque psoriasis is associated with basal keratinocyte proliferation, neutrophil or lymphocyte infiltration. So in case of pemphigus, it should be IgG deposition throughout the epidermis, and linear IgG deposition at the dermal epidermal junction occurs in case of pemphigoid. Pemphigus can be differentiated from pemphigoid on biopsy by the presence of IgG deposition throughout the epidermis in contrast with pemphigoid. So in case of pemphigus, it will be at the most superficial layer at the epidermis, and in case of pemphigoid, it should be at the dermal epidermal junction. And usually, the antibodies detected are either anti-DSG1 or anti-DSG3, and hydrosteroid is the mainstay of the treatment. Basal keratinocyte proliferation, neutrophil or lymphocyte infiltration are the features of plaque psoriasis. And then granular IgG deposition is seen in case of dermatitis herpetiformis, and linear IgG deposition at the dermal epidermal junction. So at a more deeper layer occurs in pemphigoid. So look at here, in case of bullous pemphigoid, there will be subepidermal blistering. That means there will be IgG and C3 deposition at the dermoepidermal junction.
What is the most likely cause of the X-ray abnormality seen here? Adenocarcinoma of the bronchus. B is bronchial carcinoid. C is sarcoidosis. D, small cell carcinoma of the bronchus. E, squamous cell carcinoma of the bronchus. A 51-year-old man is reviewed in the respiratory clinic. He has a chronic cough, which was worsened over the last 3 months. He has also developed hypertension and diabetes mellitus. He smokes 30 cigarettes per day. On examination, his blood pressure is 155 by 98, while his pulse is 78 and regular. He has wheeze on auscultation of the chest, consistent with COPD. His body mass index is 28 kilogram per meter square. Hemoglobin is 132, WBC 8.7, platelets 209, sodium 145, potassium 3.2, and bicarbonate is 34, creatinine is 110. A chest X-ray is conducted and shown below.
So there is an unilateral hilar muscle, and this is located on the central position, on the central portion of this lungs field. And if we look at the parameters here, most likely this patient has the underlying pulmonary cancer, and the elevated bicarbonate level points towards the metabolic alkalosis, and metabolic alkalosis is often associated with the Cushing syndrome. So Cushing syndrome is associated with which paraneoplastic lung disease or lung cancer? Is it small cell or squamous cell?
Yes, small cell.
Yes, very good. This is associated with the small cell, and the squamous cell is associated with the which one? There should be features of hypercalcemia.
Parathermal.
Yes, parathyroid. So the squamous cell lung cancer will have the features of hypercalcemia due to increased release of parathyroid hormone related peptide. Adenocarcinoma occurs in the absent smokers. A for adenocarcinoma, A for absent smoker, and A for asbestosis. Small cell lung cancer may come up with the features of SIADs, coming up with hyponatremia or with the Cushing syndrome as well as the Lambert-Eaton myasthenic syndrome. So most probably this is a case of small cell carcinoma of the bronchus. And in case of sarcoidosis, there should be no features of malignancies here. And the patient we would expect the bilateral hilar lymph node in case of sarcoidosis. But here there is only unilateral lymph node distributed on the central jaw. And adenocarcinoma usually occurs in the absent smoker, but this patient has a history of chronic smoking. And the bronchial carcinoid is usually seen in the younger patient, and patient will comes up with the features of either cherry red lesion on the lung or with the features of hemoptysis. This patient exhibits typical symptoms of Cushing syndrome, hypokalemic metabolic alkalosis with hypertension and hyperglycemia. So look at here, hypokalemic metabolic alkalosis with hypertension as well as the features of obesity. So all these things are pointing towards the Cushing syndrome, which is associated with the small cell lung cancer. Given the history of cigarette smoking and the hilar mass, a small cell bronchial carcinoma driving ectopic ACTH secretion is the most likely diagnosis. Small cell lung cancer are also associated with ectopic secretion of ADH hormone. Treatment of the underlying tumor can drive reduction in the level of ectopic hormone secretion. And adenocarcinoma usually occurs in the peripheral region, but in the picture it was the central tumor. And bronchial carcinoma occurs in the younger patient. Patient will come with features of hemoptysis, and on bronchoscopy we will see that cherry red lesion. And this type of patient may also ultimately develop the carcinoid syndrome, which should be investigated by the 5-hydroxytryptamine or 5-hydroxyindole acetic acid. And sarcoidosis will have no features of malignancy, occurring mostly in the Afro-Caribbean patient having the bilateral hilar lymph node involvement. And squamous cell lung cancer is related to the hypercalcemia, but here the calcium level was normal. Sorry, they haven't given the calcium level.
What is the most likely cause of this patient's shortness of breath? A. Invasive aspergillosis. B. Progression of primary lung lesion. C is pulmonary embolism. D is radiation pneumonitis. And E is secondary lung cancer. A 73-year-old man is reviewed in the oncology clinic having recently undergone radiotherapy for peripheral lung cancer. Panel A, the image below. He has complained of increasing shortness of breath over the last 2 or 3 months, coupled with a dry cough. Markings of the radiotherapy are seen on the images to the right. Follow-up images at 4 months and 1 year are shown in the panels B and C.
So this patient is taking the radiotherapy and comes up with the features of shortness of breath and along with the dry cough. And they have given the MRI radiography here. So there is a patchy consolidation here. So another patchy consolidation as well as the patchy consolidation. So features of patchy consolidation plus history of radiotherapy with a dry cough. What may be the most likely diagnosis?
Radiation pneumonitis.
Yes, very good. This is the case of radiation pneumonitis. This patient has a patchy consolidation at 4 o'clock. Okay, just let me show you another thing. So if we draw it like this is 12 o'clock position. This is 6 o'clock position. This is 9 o'clock. This is 3 o'clock. So this will indicate the 2 o'clock position. And if we consider in this picture, so along this position is the 3. So this is showing the 4 o'clock position. So that's why they have said regarding the 4 o'clock. This patient has a patchy consolidation at 4 o'clock on the MRI images of the left lung. This is first seen at the 4-month mark and is also present on the image at 1 year. And this usually 70% radiation dose is related to the radiation pneumonitis. Choice of treatment should be inhaled steroid followed by oral steroid.
What is the most appropriate intervention for this patient? A. Counseling. B. Diazepam. C. Eye movement desensitization and reprocessing. D is relaxation therapy, and E is sertraline. A 26-year-old man presents to his GP 3 months after a car accident. He describes how it is becoming increasingly difficult for him to attend work due to stress. He is experiencing persistent flashbacks of the accident and nightmares 3 to 4 times per week. In conversation, he finds himself continuously ruminating on events and wonders if they could have been experienced differently. While he is at work, he is constantly agitated and expects negative events to occur. He suffers from panic attacks each time he hears an alarm going off. What is the most appropriate intervention for this patient?
So diagnosis. So recurrent nightmare, flashbacks, and emotional detachment points towards the post-traumatic stress disorder, and the most appropriate intervention should be eye movement desensitization and reprocessing therapy, in short, EMDR. So remember, recurrent nightmare, flashback, and emotional detachment. So persistent flashback, nightmare, as well as there has been emotional detachment here. So this is a case of post-traumatic stress disorder, PTSD, and the first line choice of intervention should be the eye movement desensitization and reprocessing therapy. This patient is exhibiting three major features consistent with post-traumatic stress disorder. He is re-experiencing events, flashbacks, and nightmare, exhibiting avoidance or rumination, as well as the hyperarousal. EMDR is the intervention of choice and can only be performed by specialists. EMDR is an integrative psychotherapy approach with a set of standardized protocols, principles, and procedures. The goal of EMDR is to reduce the distress in the shortest period of time.
What is the most appropriate intervention? A. Amoxicillin. B. Ciprofloxacin. C. Cotrimoxazole. D is doxycycline. E. Metronidazole. A 21-year-old man presents to the emergency department complaining of fever with severe fatigue, rigors, myalgia, and a retroorbital headache with photophobia. He also reports a dry cough and shortness of breath over the last 3 days. He has a maculopapular rash. He has recently returned from working on a sheep farm a few days ago. On examination, his temperature is 38.3, his blood pressure is 105 by 80, while his pulse is 95 beats per minute and regular. Wheeze and scattered coarse crackles are heard on auscultation of the chest. Hemoglobin is 137, WBC is 11.7, platelet is 422, sodium is 133 low, potassium is 4.7, creatinine is 118, ALP 201, AFB is 292, CRP is 141, and X-ray chest shows patchy bilateral consolidation. What is the most appropriate intervention?
So can you tell me the diagnosis from here?
Please write on your receive.
Sorry.
Please on your receive.
So, so features of atypical pneumonia with hyponatremia, abnormal liver function test with elevated transaminase, reactive lymphocytosis, often with history of the lambing sheep, and chest X-ray showing the patchy consolidation points towards the Q fever, and Q fever should be treated with doxycycline 100 milligram BD for 2 weeks. So history of atypical pneumonia with hyponatremia, elevated transaminase, chest X-ray showing bilateral patchy consolidation, as well as the Weissen's scattered corpus points towards the Q fever. And there is also history of the sheath form as well. So all the speeches are suggestive of the Q fever. And hyponatremia with features of pneumonia is associated with two conditions. One is the Legionella, and another one is this Q fever. And in case of Legionella, they will usually give the history of the either poor air conditioning system or staying in a foreign hotel. And in case of Q fever, the patient they will give history of the sheep or sheep grazing. This patient has atypical pneumonia with a low sodium level, abnormal liver function test, and patchy consolidation on this chest X-ray. A diagnosis of Q fever should be suspected given exposure to lambic sheep on his uncle's sperm. Reactive thrombocytosis is also seen, reflected by platelet level above the normal range. So there is a reactive thrombocytosis as well. Doxycycline is the intervention of choice for acute Q fever and is usually given at a dose of 100 milligram twice a day for 2 weeks. So 100 milligram BD for 2 weeks. And the features would be atypical pneumonia with low sodium level, as well as the abnormal liver function test, patchy consolidation, and we can also expect the reactive thrombocytosis. And if doxycycline is contraindicated, for second line, we can go with the cotrimoxazole as well. And cotrimoxazole can also be given in case of pregnancy along with folic acid. Okay, next.
What is the most likely cause of this patient's symptom? A is amlodipine, B dapagliflozin, C metformin, D ramipril, E sertraline. A 49-year-old man presents to the emergency department with stridor and an erythematous rash affecting his face and neck and symptoms of hypotension. This is the third episode that he has experienced in the last 6 months. He has type 2 diabetes, anxiety, and hypertension. His current medications are ramipril, amlodipine, sertraline, dapagliflozin, and metformin. What is the most likely cause of the patient's symptom?
So stridor and erythematous rash following use of ramipril points towards the ACE inhibitor induced angioedema. So angiotensin converting ACE, the angiotensin 1 is converted to angiotensin 2 with the help of angiotensin converting enzyme, and in this pathway the bradykinin is metabolized to the inactive components, and if we are blocking this pathway, then the bradykinin won't be metabolized, leading to accumulation of bradykinin, and which will lead to the features of stridor, erythematous rash, as well as the angioedema. Rates of angioedema approximately 0.7% of ACE inhibitors. In more than half of the cases, these episodes occur during first week of therapy. Withdrawal of ramipril is essential because of the risk of fatal episode occurring. Angioedema is thought to occur as a result of elevated levels of bradykinin in patient taking an ACE inhibitor. Switching to an alternative antihypertensive medication like the angiotensin receptor blocker is one of the options.
What is the most important intervention in this patient? A. IV flumazenil, B. IV lidocaine, C. IV normal saline, D. IV phenytoin, E is IV sodium bicarbonate. A 42-year-old woman is brought to the emergency department by her boyfriend following an overdose. She is known to have depression and is thought to have consumed a large quantity of whiskey and a bottle of 50 milligram amitriptyline tablets. On examination, her blood pressure is 100 by 70, while her pulse is 95 beats per minute and regular. Her GCS is 8 on arrival. As she is examined, she suffers a short tonic-clonic seizure. Hemoglobin is 132, WBC is 11, platelets 103, potassium, sodium is 144, potassium is 5.4, bicarbonate is 12, creatinine is 215, and ECG shows QRS of 120 ms. What is the most important intervention for this patient?
So this is the patient with TC or amitriptyline poisoning or amitriptyline overdose. So what should be the most appropriate intervention? Just remember,
Sodium bicarbonate.
yes, very good. We should go with the IV sodium bicarbonate. And just remember the shortcut formula: TCA overdose or amitriptyline overdose plus QRS duration greater than 100. Go with the IV sodium bicarbonate. So what should be the dose of IV sodium bicarbonate? It should be 8.4%, 100 milligram. Okay. So TC overdose, QRS duration greater than 100 millisecond. Go with IV sodium bicarbonate, 100 ml, 8.4% sodium bicarbonate. And according to other some guidelines, they also said 1 ml per kg body weight. But as a rough estimation, you can remember 100 ml, 8.4%. This patient is experiencing a significant TCA overdose coupled with acidosis and QRS prolongation and has suffered a seizure. In this situation, sodium bicarbonate is a proven benefit. It is usually given at a dose of 1 millimole per kg IV, aiming for a pH target of 7.5. In the event that is achieved, the risk of ventricular arrhythmia, seizure activity is significantly reduced. And flumazenil is the antidote for benzodiazepine overdose.
What is the most appropriate management option? A. Compression bandaging. B. Oral co-amoxicillin. C. Oral prednisolone. D. Topical fusidine. E. Topical hydrocortisone. A 66-year-old man presents to the dermatology clinic with swelling and skin changes affecting both lower limbs. He has type 2 diabetes and is obese. His current medications are metformin, ramipril, atorvastatin, and aspirin. On examination, his blood pressure is 152 by 84, while pulse is 75 regular. There is pitting edema below both knees, erythema, and eczematous changes. There is hyperpigmentation over the medial side of both ankles. He has a normal pulse in both feet. What is the most appropriate management option?
So diagnosis: hyperpigmentation or ulceration over the medial malleolus constitutes the venous ulcer. Number one. Number two, the normal pulse. This is excluding the art- this is excluding
Arterial.
the this is excluding the arterial insufficiency. And in case of venous ulcer, there would be excessive accumulation of the hemosiderin in the dermal layer, which will lead to the eczematous changes. So what should be the choice of what should be the management in case of chronic venous ulcer or chronic venous insufficiency?
Compression
Compression
bandaging.
bandage.
Yes, very good. We should go with the compassion bandage. Very good. This patient presentation is consistent with status dermatitis affecting both lower limbs. This is likely a result of his obesity and chronically increased abdominal pressure with a poor venous return. Keeping the patient leg elevated with compassion bandaging is likely to improve his symptoms. Weight loss over the long term is the key intervention. So for venous ulceration, when the arterial insufficiency has been excluded, you can go with the CB, compassion bandage.
What is the most appropriate intervention in this patient? A. Finasteride. B. Intermittent self-catheterization. C. Oxybutynin. D. Rotating antibiotics. E. Suprapubic catheter. A 41-year-old woman presents to the neurology clinic for review. She has suffered from urinary incontinence and urinary tract infections for several years. Investigations have now revealed a large atonic bladder. She is thought to have an overflow incontinence. She has progressive multiple sclerosis. She attends the clinic in a wheelchair, although her upper limb function appears to be intact. Routine blood testing is unremarkable. What is the most appropriate intervention in this patient?
So how to treat a case of multiple sclerosis patient having the hypotonic or overflow incontinence?
Intermittent self-catheterization.
Yes, very good. We should go with the intermittent self-catheterization. This should be the most appropriate choice of intervention if a patient with multiple sclerosis comes up with the overflow incontinence. And finasteride is the 5-alpha reductase inhibitor, which is used in the management of benign prostatic hyperplasia. And oxybutynin or tolterodine, they are usually the first line pharmacological therapy in a patient with arch incontinence. Intermittent self-catheterization is the intervention of choice for this patient with multiple sclerosis who has a large hypertonic bladder. Sufficient hand and arm function to cope with the dexterity needed to self-catheterize is key, as is preservation of sensation in the perineal area. This is associated with lower risk of urinary tract infection versus compared to other options like the suprapubic catheter. And finasteride is the 5-alpha reductase inhibitor. This will cause reduction in the prostatic volume, and this is often given as an additional therapy along with the alpha receptor blocker like the prazosin or tamsulosin in the management of benign prostatic hyperplasia. And oxybutynin, this is the anticholinergic. This is the first line pharmacological therapy in case of arch incontinence, except in the elderly people or if a patient has features of confusion or neurological disorder. So what should be the choice of treatment if a patient with arch incontinence comes with neurological disorders? What should be the choice of drug? We should go with the mirabegron. And mirabegron is the beta 3 receptor agonist.
What is the most likely diagnosis? A. Chronic myeloid leukemia. B. Felty syndrome. C. Methotrexate related bone marrow suppression. D is non Hodgkin lymphoma. E is parovirus B19 infection. A 65-year-old woman presents to the rheumatology clinic for review. She has rheumatoid arthritis and previously presented to her GP with a respiratory tract infection. She was also noted as being neutropenic. Her disease activity is thought to be low at the moment. Over the past few months, she admits to suffering from intermittent fevers and weight loss. On examination, she looks pale. There are extensive rheumatoid nodules and joint damage due to previous active synovitis. Hepatosplenomegaly is seen on abdominal palpation. Hemoglobin is 91, WBC is 6.1, neutrophils are 0.3, platelet is 153, sodium 144, potassium 5.4, creatinine is 120. X-ray chest shows multiple rheumatoid nodules. What is the most likely diagnosis?
So long-standing rheumatoid arthritis plus neutropenia plus hepatosplenomegaly. So what will be the most likely diagnosis?
It's Felty syndrome.
Yes, very good. This is the case of Felty syndrome. So why not methotrexate related bone marrow suppression? Bone marrow
Yeah,
suppression will bone marrow suppression will
WBC normal.
Yes, bone marrow suppression will comes up with the features of pancytopenia, but here we are getting the isolated neutropenia with mild anemia, and other features are also suggestive of the Felty syndrome. So, how to treat a case of Felty syndrome?
Like pulsed corticosteroid therapy.
Yes, pulse corticosteroid therapy, and we should reduce the dose of the methotrexate. Felty syndrome is seen in association with rheumatoid arthritis. It is thought to be the result of loss of immune tolerance to self-antigens and subsequent neutropenia. Felty syndrome is more commonly seen in patients with long-standing disease, leg ulcer, and increased skin pigmentation are also seen. Although methotrexate can lead to bone marrow suppression, it is the initial intervention of choice increased doses is the first step in management. And in case of methotrexate related bone marrow suppression, we will get the features of pancytopenia. Non-Hodgkin lymphoma is more likely to present with painless progressive lymphadenopathy. And parvovirus B19 infection can cause red cell aplasia in patients with chronic hemolytic anemia. Parvovirus infection can also lead to precipitous fall in hemoglobin in sickle cell disease and hereditary spherocytosis. And in case of parvovirus B19 infection, there should be at least one of this underlying pathology as well.
What is the most likely cause of this patient's abnormal LFTs? A. Autoimmune hepatitis. B. Cholelithiasis. C. Non-alcoholic fatty liver disease. D is primary biliary cholangitis. E. Primary sclerosing cholangitis. A 54-year-old woman is reviewed in the hepatology clinic. She has Graves' thyroiditis, which is controlled with blocked replace therapy, including carbimazole and thyroxine. Her GP has noted abnormal liver function on routine blood monitoring. On examination, her blood pressure is 122/82, heart rate is 78, BMI is 23, abdomen is soft and non-tender with no masses. Hemoglobin is 111, WBC is 9, platelet is 129, sodium 143, potassium 4.3, creatinine 102, ALT is 97, and ALP is 310. Bilirubin is 18. Autoantibody profile shows anti-mitochondrial antibody positive, and ultrasound scan of the liver shows evidence of fibrosis. What is the most likely cause of this patient's abnormal LFTs?
So this patient has the underlying diagnosis of the Graves' thyroiditis, and the patient is also a middle-aged female patient with AMA positivity. So what can be the most likely diagnosis? Middle-aged mom, PBC is the amma disease. So middle-aged mom with AMA positivity is the primary biliary cirrhosis or cholangitis. And in case of PBC, we'll get the elevated alkaline phosphatase. And the autoimmune thyroid diseases are also associated with the primary biliary cirrhosis. And in case of autoimmune hepatitis, we will get the asthma antibody would be positive instead of the anti-mitochondrial antibody. In case of cholelithiasis patient, you will usually have patient would be the obese patient, but here the BMI is normal, and this usually comes up with the features of right upper quadrant pain, and the antibody profile would be negative here. Non-alcoholic fatty liver disease occurs in the obese patient, and there should be no antibody here as well. And PSC is associated with the ulcerative colitis. Primary biliary cholangitis occurs with increased frequency in patients with autoimmune thyroid. PBC accounts for obstructive liver function test, positive anti-mitochondrial antibodies, and evidence of fibrosis on the liver ultrasound. Abnormal LFTs are also seen in patients treated with thioamide drugs such as carbimazole. So PBC may be associated with autoimmune thyroid disorder, and on ultrasound we will get the features of fibrosis. And AIH will have the asthma antibody. Cholelithiasis will come with obstructive lung liver function test, and there should be right upper quadrant pain, and the patient would be obese patient. And in non-alcoholic fatty liver disease, overweight or obese patient with fatty infiltration or features of fibrosis, and PSC is equal to ulcerative colitis.
What is the most appropriate investigation for this patient? A. Disintegrated and metalloproteinase with a thrombospondrin type 1 motif, member 13, which is Adam TS13. B is complement C3, and C is D dimers, D is lactate dehydrogenase, E is stool culture for is E. coli. 24-year-old woman is admitted to the hospital with diarrhea, fever, and abdominal pain. She has been feeling increasingly unwell over the past 2 days. On examination, her blood pressure is 139/84, Pulse is 95 regular. Abdomen is soft but generally tender with active bowel sounds. Hemoglobin is 92. Fragmented red cells are seen on blood film. White cell WBC is 11.7. Platelet is 76. Sodium is 144. Potassium is 5.4. Creatinine is 215. What is the most appropriate investigation for this patient?
So this patient has comes up with the features of diarrhea, fever, abdominal pain, and there is features of hemolysis evidenced by fragmented vessel with leukocytosis, thrombocytopenia, and there is presence of renal impairment. So hemolysis plus renal impairment plus diarrhea, fever, abdominal pain. What may be the most likely diagnosis in a young patient?
HUS.
Yes, very good. So this is a case of hemolytic uremic syndrome. So what should be the most appropriate investigation in HUS?
Stool culture for E. coli.
Yes, we should go with the stool culture for the E. coli. And who is disease is related to the Adam TS13?
TTP.
Yes, very
TTP.
good. The TTP is related to the Adam TS13. What are the printed for TTP? And how to differentiate TTP from HUS?
TTP would have neurological symptom.
Yes, very good. TTP will have the neurological symptoms, and in case of HUS, there would be no neurological symptoms. So the neurological signs, this points toward the thrombotic thrombocytopenic pathway, and this is related to inhibition or deficiency of the ADAM TS13, and they will have the pentate containing fever, neurological signs, thrombocytopenia, hemolytic anemia, renal failure. And this neuroscience differentiates TTP from the hemolytic uremic syndrome. And in case of TTP, there should be mild renal impairment, but in case of HUS, there should be significant renal impairment. So we are getting a significant renal impairment here, and there's no neurological features here. So most likely diagnosis is the HUS. This patient presentation suggests that she has become infected with Shiga toxin producing E. coli. This can result in hemolytic uremic syndrome with microangiopathic hemolytic anemia and acute renal failure. By the time patient presents, they are usually no longer shedding bacteria. However, for public health reasons, it's still important to confirm the diagnosis. Patients are usually managed with supportive therapies. Early plasma exchange, equilibrium may be valuable. And Adam TS13, this is related to the TTP, and patient will have the neurological complaints.
What is the most appropriate initial intervention in this patient? A. Azathioprine. B. Adorphonium. C. Prednisolone. D. Pyridostigmine. And E. Rituximab. 49-year-old woman is referred to the neurology clinic with gradually worsening weakness over the past few months. She tells you that by the time it gets to the end of the evening, she is unable to focus on the television or to read because of eye fatigue. She is finding it difficult to perform her job. She has no medical illness and takes no regular medication. On examination, her BP is 122 by 81, pulse is 67 regular. She is unable to maintain an upward gaze for more than a few seconds. While there is also some weakness of the shoulder girdle, and hip flexors. Hemoglobin is 132, WBC 7.7, platelet is 376, sodium 142, potassium 3.9, creatinine 95, and acetylcholine receptor antibody is positive. What is the most appropriate initial intervention in this patient?
So acetylcholine receptor antibody positivity plus features of ptosis. So what may be the most likely diagnosis?
Myasthenia gravis.
Yes, very good. Myasthenia gravis. So what is the most appropriate initial intervention in myasthenia gravis?
Pyridostigmine.
Yes, we should go with the pyridostigmine. So pyridostigmine is the short-acting anticholinesterase inhibitor. It is used in the management of myasthenia gravis, and rifostigmine is the long-acting anticholinesterase inhibitor, which should be used in the management of Alzheimer's disease. And if a patient with myasthenia gravis does not respond to pyridoxine, what should be the second line drug? The second line drug should be the steroid. And if the patient is still not responsive to steroid, third line drug should be steroid sparing azathioprine. And the fourth line of drug should be the biological drugs or the anti-CD20 drug like the rituximab. And always remember, pyridostigmine is the first line or initial intervention in case of myasthenia gravis. And edrophonium was previously used as a part of diagnostic test to diagnose the myasthenia gravis. This is not for the therapeutic purpose. This is for the diagnostic purpose. Pyridostigmine is a cholinesterase inhibitor. It is the initial treatment of choice for patients with myasthenia gravis who demonstrate mild to moderate disease clinically. The diurnal variation of fatigue, inability to sustain an upward gaze, and positive acetylcholine receptor antibody seen in this patient are hallmark of the myasthenia gravis. The usual dose of pyridostigmine is 600 milligram daily, adequately spaced to allow for control of muscle weakness during the course of the whole day. Immunosuppression is then added, beginning with the corticosteroid. And if the patient does not respond to pyridostigmine, then go with steroid. No response to steroid, go with steroid sparing agent like azathioprine. Still not responsive, go with the anti-CD20 or with the biological drugs. And edrophonium is for the diagnostic purpose. Edrophonium was previously used as a diagnostic test for myasthenia gravis.
What is the most appropriate intervention for this patient? A is botulinum antitoxin, B IV immunoglobulin infusion IVIG, C is IV penicillin, D plasma exchange, E prednisolone 60 mg per day. A 34-year-old man is admitted to the emergency department with muscle weakness, having recently returned from a trip to Sweden where he ate some locally canned fish. On examination, he has blurred vision, slurred speech, difficulty speaking. His pupils are dilated bilaterally, and there is a failure of accommodation. He is unable to look up because of eye muscle fatigue. He is apyrexial. His blood pressure is 138 by 82, pulse is 72 regular. He feels short of breath when he lies flat. His oxygen saturation is 92% on air. There is 4 by 5 power weakness affecting his shoulder girdle. Hemoglobin is 138, WBC is 11.7, platelet is 304, sodium is 144, potassium is 4.7, creatinine is 112. And what is the most appropriate intervention for this patient?
So can you tell the diagnosis? So this patient is having the features of bulbar palsy, as well as there is central muscle weakness, and there is also shortness of breath on lying flat. Shortness of breath on lying flat, this is pathognomonic of the botulinum toxin, and eating locally canned fish or canned fish toxicity induced can also point towards the botulinum toxin, botulinum or the own botulism. So what should be the most appropriate treatment for botulinum infection? So what should be the treatment in botulinum infection? Plasma
Antitoxin.
Yes, very good. We should go with the botulinum antitoxin and IVIG and plasma exchange. These two are the choice of treatment in case of Guillain-Barré syndrome. And in case of Guillain-Barré syndrome, patient will have the flaccid type of descending paralysis, and especially they will more affect the peripheral parts of the body. But in case of botulinum toxin, the patient will have the features of bulbar palsy as well as central weakness with eye muscle fatigability and short of breath on lying flat. This is one of the pathognomonic features of botulinum infection. This patient demonstrates central muscle weakness with the evidence that it is beginning to descend, that is reduced oxygen saturation, which worsen when he lies flat. Given that this patient has ingested local cane fish, botulinum should be considered. Botulinum toxin, which is already bound to the neuromuscular junction, will not be affected by antitoxin, but injection of antitoxin should further progression of muscle weakness. Close monitoring of respiratory function is essential. Progressive respiratory failure is a common in patient with botulinum, and IVIG infusion as well as the plasma exchange. These two are the choice of treatment in case of GBS, Guillain-Barré syndrome.
Which of the following autoantibodies is most likely to be associated with this patient's muscle weakness? A is anti-glutamic acid decarboxylase, B is anti-Jo1, C is anti-MI2, D anti-smooth muscle, and E is anti-tissue transglutaminase. A 43-year-old woman presents to the rheumatology clinic for review. She has been experiencing proximal muscle weakness, which fluctuates from week to week, but this has steadily worsened over the last 6 weeks. She has also been experiencing fatigue and short of breath over the last few months. She has celiac disease, but this is well controlled. On examination, her blood pressure is 110/80. Pulse is 66 regular, 4 by 5 power weakness affecting both her shoulder girdle and hip flexors is also observed. She has no skin rashes. Hemoglobin is 102, WBC 8.1, platelets 381, sodium is 143, and potassium is 4.8. Creatinine is 110, and corrected calcium is 2.4. Creatinine kinase is 1341. Which of the following autoantibodies is most likely to be associated with this patient's muscle weakness?
So significant elevation in the creatinine kinase with proximal myopathy. So what may be the most likely diagnosis? Anyone? Significant elevation in creatinine kinase.
Polymyositis.
Yes, very good. So this is the case of polymyositis. So which antibody is related to polymyositis?
Anti-Jovan, I guess.
Yes,
Anti-Jo1.
anti-CHO1 is associated with polymyositis. So what is the confirmatory diagnostic test for polymyositis? We should go with the muscle biopsy.
One of our exam questions. No, sir.
So muscle biopsy is the confirmatory diagnosis of polymyositis, but the anti-CHO1 antibody is also associated with polymyositis in around 20% cases. And anti-GAD, which condition is associated with anti-glutamic acid decarboxylase?
Stiffman syndrome.
Yes,
Attacks here.
this is related to the stiff person syndrome, SPS. GAD is equal to SPS. And anti-MI2, anti-MI2 is usually found in case of dermatomyositis. And anti-smooth muscle asthma is found in autoimmune hepatitis. And anti-TTG is found in case of celiac disease. So since the features are suggestive of polymyositis, so most likely antibodies positive would be the anti-CHO1 antibody. This patient is experiencing proximal muscle weakness and the marked elevation in creatinine kinase. In the absence of a rash, polymyositis is the most likely underlying diagnosis, and in around 20% cases, polymyositis are associated with anti-CHO1 antibody, and they are also associated with interstitial lung disease, especially the pulmonary fibrosis. Muscle biopsy is the diagnostic for this condition, and corticosteroid are the intervention of choice. And anti-GAD in case of SPS, stiff person syndrome, anti-MI2 is associated with dermatomyositis, asthma in case of autoimmune hepatitis, anti-TTG with celiac disease.
What is the most likely cause of this patient's thyrotoxicosis? A. Abuse of thyroxine tablets. B. Graves' disease. C. Multinodular goiter. D. Subacute thyroiditis. And E is thyroid adenoma. 39-year-old woman come to the endocrine clinic to discuss the result of a thyroid uptake scan. She presents to her GP with palpitations and weight loss, while her thyroid stimulating hormone level was found to be less than 0.05 milliunit per liter. Normal range is 0.3 to 3. Her thyroid uptake scan is shown below.
So this is the thyroid uptake scan, and here the features are suggestive of the thyrotoxicosis. So is the peak clear or is it blurring?
Clear.
Okay, look at here. This is the normal uptake, and this is the increased diffuse uptake, which is often seen in case of Graves' disease. And in case of Hashimoto's thyroiditis, there will be reduced uptake with scattered uptake, and multinodular goiter will have the nodular shaped uh, uptake. So the increased diffuse uptake is related to the Graves' disease. So here has been the diffusely increased uptake throughout the entire thyroid gland. So this points towards the Graves' disease, and also the thyrotoxicosis is associated with Graves' disease. This patient is demonstrating symptoms of thyrotoxicosis, weight loss, palpitation, and suppressed TSH, and the thyroid uptake scan is showing uniform increased uptake. So there the uniform increased uptake throughout the entire gland. Graves' disease is the most likely diagnosis. Block and replace therapy combination with high-dose carbimazole and high-dose thyroxine is the optimal treatment. Treatment dose radioactive iodine is the intervention of choice for Graves' disease, assuming that there is no contraindication. So, what is the contraindication for radioiodine therapy in case of Graves' disease?
Eye problems
Eye,
with Graves' disease.
Yes.
eye symptoms.
Number one, if the patient is pregnant, and number two, the decompensated thyroid eye disease.
What is the most likely cause of his symptoms? A. Dilated cardiomyopathy. B. Hypertrophic obstructive cardiomyopathy. C. Intermittent heart block. D is paroxysmal atrial fibrillation. E is paroxysmal ventricular tachycardia. A 41-year-old man presents to the cardiology clinic for review. He has suffered from lightheadedness and pre-syncope with an intermittent fast palpitations over the past 3 months. He has myotonic dystrophy but endeavors to maintain his physical strength as much as possible with regular physiotherapy. On examination, his blood pressure is 125/82, pulse is 70 and regular. What is the most likely cause of his symptoms?
So patient with myotonic dystrophy and has come up with the features of lightheadedness, pre-syncope, and intermittent fast palpitation. So which condition is often associated with myotonic dystrophy?
Heart block.
No, not the heart block. Either there should be increased chance of atrial tachycardia, and atrial tachycardia means paroxysmal atrial fibrillation. And this features lightheadedness, pre-syncope, intermittent fast palpitation can be explained with the help of paroxysmal atrial fibrillation. Atrial tachycardias are most commonly seen in patients with myotonic dystrophy, and this fits with the episodes of pre-syncope, fast palpitation reported here. Atrial tachycardias may affect up to 25% of patient with myotonic dystrophy. Confirmation of the diagnosis with 24-hour electrocardiogram, that's the ECG. Monitoring is the next step, to be followed by electrophysiological study. Symptomatic intermittent heart block is less frequently seen in myotonic dystrophy compared to tachycardia. The atrial tachycardia is more common compared to intermittent heart block. Intermittent heart block may occur, but this is less frequent compared to atrial tachycardia. Despite this, if the patient are seen to be at high risk of progression, they should be assessed for heart block and considered for pacemaker placement. So the most common association is with the atrial tachycardia in the form of paroxysmal atrial fibrillation.
What is the most likely diagnosis? A. Branch retinal artery occlusion. B. Branch retinal vein occlusion. C is central retinal artery occlusion. D. Central retinal vein occlusion. E. Hypertensive retinopathy. A 34-year-old woman presents to the emergency department complaining of sudden onset blurred vision affecting the lower half of her left visual field. She previously experienced a left DVT and has a heterozygous protein C deficiency. A retinal photograph is shown below.
So how to differentiate central retinal vein occlusion from central retinal artery occlusion?
Central retinal vein, flame-shaped hemorrhage. Central retinal artery, cherry red spot.
So both central retinal vein occlusion and central retinal artery occlusion, both of them will come with painless loss of vision. And in case of vein occlusion, we'll get the flame-shaped hemorrhage, and often patient has underlying association with deep vein thrombosis or diabetic mellitus or dyslipidemia. And this flame-shaped hemorrhage is known as the stormy sunset appearance. And central retinal artery occlusion will come with pale retina and shady red spot. And in both cases, if the central artery or central vein is involved, then there should be this type of picture in the entire quadrant of the. But here there is a flame-shaped hemorrhage only in the upper quadrant, and this is giving rise to a flame-shaped hemorrhage. So if the flame-shaped hemorrhage only affects the upper quadrant, what should be the most likely diagnosis?
Branch retinal vein occlusion.
Yes, very good. This is the branch retinal vein occlusion. And in case of central retinal vein occlusion, we would expect this type of flame-shaped hemorrhage in the entire quadrant. So look at here, the central retinal vein occlusion in the form of stormy sunset. This is having the involvement in the entire quadrant, all through the eyes. The entire quadrant is being affected. And in case of branch retinal, usually the upper quadrant or the lower quadrant, only a portion of the quadrant would be affected, not the entire one. And look at here, this is the pale retina and this is known as the cherry red spot. Okay, look at here, the pale retina, the retina is pale whitish in color and there is a cherry red spot. So pale retina, cherry red spot points toward the central retinal artery occlusion. And in case of branch retinal artery occlusion, there should be pale retina in one of the quadrant only, not throughout the entire quadrant. So a portion of the quadrant will only have the pale retina. like this. And in case of hypertensive retinopathy, we usually get the features of like hard exudate or the cotonou spot. So features of hypertensive retinopathy based on those stages: cotonou spot, this type of yellowish color; silver wearing, these are known as the silver wearing. There may be hard exudate. Hard exudate are also yellowish in color. In some cases, arteriovenous nipping, and also features of papilloedema. So this is the arteriovenous necking, and there is narrowing of the arteriolar wall. Often we see the disc edema as well as the exudate, yellowish color. This patient has developed sudden painless visual loss with flame hemorrhage over the upper half of the retina. These retinal changes correspond to the loss of visual acuity over the lower half of the visual field. The occlusion is potentially related to congenital protein C deficiency and will drive commitment to lifelong anticoagulation. Neovascularization can develop over time and may require photocoagulation. And branched retinal artery will have the pale retina in either upper quadrant, lower quadrant, or in a portion of the quadrant. And central will affect the entire quadrant. And hypertensive retinopathy will come with features of hard exudate, cotonou spot, and often we see the papilloedema. And this hypertensive retinopathy is usually a painful condition, not the painless visual loss. Painless visual loss occurs in a branch occlusion. Sorry, painless visual loss occurs in either vein occlusion or arterial occlusion. Okay, next one.
What is the most appropriate next intervention? A. Increase bisoprolol to 5 mg. B. Increase furosemide to 80 mg. C. Increase ramipril to 5 mg. D. Start ivabradine 5 mg. E. Start spironolactone 25 mg. A 78-year-old man presents to the cardiology clinic following a referral by his GP. He has been admitted to hospital 3 times in the last 6 months with left ventricular failure. His current medication include 2.5 mg bisoprolol, 2.5 mg ramipril, and 40 mg furosemide. On examination, his BP is 148/82, pulse is 88. He has an early diastolic murmur, loudest in the aortic area. On auscultation of the chest, bilateral basal crackles consistent with heart failure and are observed. Hemoglobin is 141, WBC is 7.6, platelet is 289, sodium 143, potassium 4.1, creatinine is 129, and X-ray chest shows bilateral upper lobe diversion. Echo shows ejection fraction 31%, moderate aortic regurg. What is the most appropriate next intervention?
So this is the patient with congestive cardiac failure or heart failure with associated aortic regurgitation, and the early diastolic murmur loudest in the aortic area. This also points towards the aortic regurgitation. So if we go for the management of heart failure, so the first line drug should be all patients should receive two drugs, A and B, ACE inhibitor and beta blockers, provided that there is no contraindication. Second line drug are the aldosterone antagonist. But before going for the second line drug, we need to increase the dose of the AC inhibitor and the beta blockers. So which one should we increase the dose first, beta blocker or the AC inhibitor? Patient is getting 25 milligram of bisoprolol and 25 milligram of ramipril. So both of them can be increased. But the question is, which one should we increase first? We should increase the dose of the AC inhibitor first, provided that there is no contraindication. And after that, we'll increase the dose of beta blocker. And after that, we will add the second line drug, aldosterone antagonist. This patient has aortic regurgitation as evidenced by the murmur. He is likely to be a poor operative candidate given the low ejection fraction. In this situation, with the systolic blood pressure of 148 millimeter of mercury, there is an opportunity to increase the dose of AC inhibitor to optimize the left ventricular function. Once AC inhibitor is maximized, increasing beta blockade may further improve in this patient's symptoms and impact on prognosis. So at first we should increase the dose of AC inhibitor followed by beta blocker. Beta blockers are associated with improved outcomes in patients with heart failure, reduced ejection fraction, and aortic regurgitation. However, in this case, it is more appropriate to increase the dose of AC inhibitor first, given that the patient has signs of left ventricular failure or auscultation of his chest.
What is the most appropriate intervention for this patient? A. Dopamine, B. Fusamide, C. N-acetylcysteine, D. Renal replacement therapy, E. Vasopressin. A 58-year-old man is recovering in the CCU following stenting for an anterior MI 3 days ago. His creatinine has risen over the last 48 hours. Over the past 8 hours, his urine output has fallen to less than 30 ml per hour. On examination, his BP is 115/80, while pulse is 74 regular. His chest is clear. His central venous pressure is 9 centimeter. Hemoglobin is 139, while WBC is 11, platelets 219, sodium is 143, potassium is 5.4, and creatinine is 495, up from 235 1 day ago. Urea is 12. What is the most appropriate intervention for this patient?
So this patient has a history of stenting followed the anterior myocardial infarction, and after that patient has developed the significant renal impairment. But the patient's the blood pressure is normal here, and as well as the central venous pressure. So can anyone tell me the normal central CVP? What is the normal CVP? The normal CVP, just remember this is 10 plus minus 2. So the range should be in between 8 to 12. So here patient has developed renal impairment following stenting with having the normal blood pressure and having the normal central venous pressure. So what may be the most likely diagnosis? Post PCI complication. Post PCI complication usually have two differential diagnoses. One is the cholesterol embolization, another one is the contrast nephropathy. So most likely here the patient has developed the contrast nephropathy due to the underlying acute tubular necrosis. So how will you treat a case of ATN induced contrast nephropathy following the PCI? How to treat contrast nephropathy? Anyone?
IV fluids.
No, not the IV fluids.
D.
And IV fluid is not also is not in the option here.
Renal replacement therapy.
Yes, very good. We should go with the renal replacement therapy. In this situation, a rapid increase in serum creatinine despite optimal fluid status coupled with normal systolic blood pressure and central venous pressure, the diagnosis is acute tubular necrosis due to contrast-induced acute kidney injury, and RRT renal replacement therapy is the only viable option. So ATN-induced contrast nephropathy should be treated with renal replacement therapy. The IV hydration may be given as the initial treatment or first line treatment, but the specific management will be the RRT, renal replacement therapy.
So what does it mean by renal replacement therapy?
The renal replacement therapy may be either in the form of hemodilatation, either in the form of a hemodialysis, or in some cases you can also go for the renal transplant.
Okay.
Okay, next one.
What is the most likely cause of this patient's lymphadenopathy? A. Cryptococcus neoformans, B. herpes zoster, C. Jones Cunningham virus, D is Mycobacterium avium complex, and E is Pneumocystis jirovecii pneumoniae, P. jirovecii. A 32-year-old man presents to the emergency department complaining of painful cervical lymphadenopathy, fever, and sweating. He has recently diagnosed with HIV and began antiretroviral therapy 7 weeks ago. His CD4 count when commencing a highly actively antiretroviral therapy was 85. On examination, his temperature is 38.2. His blood pressure is 122 by 80. His pulse is 85 and regular. His chest is clear, while his abdomen is soft and non-tender. He has tender cervical lymphadenopathy. Investigations are hemoglobin is 92
Sorry, yeah,
or yeah,
92,
it
92.
is 92. WBC is 8.1. CD4 lymphocyte count is 231. Platelet is 192. Sodium is 143. Potassium is 4.3, and creatinine is 112. What is the most likely cause of this patient's lymphadenopathy?
So this is the patient with with underlying HIV, and during commencing the heart therapy, his CD4 count was 85, and now it has increased to 231. So which condition is associated with the cervical lymphadenopathy in a patient with underlying HIV? Most common cause?
Mycobacterium
Yes, very good.
avium complex.
The Mycobacterium avium complex, this is related to the features of Irish immune reconstitution syndrome, and the features are also suggestive of the immune reconstitution syndrome, like the raised temperature with uh, tender cervical lymph node involvement. So the MAC, the Mycobacterium avium complex, this is related to the lymphadenopathy in a patient with HIV. The cervical lymphadenopathy seen here fits well with the reactivation of the Mycobacterium avium complex symptoms in patient with immune reconstitution inflammatory syndrome. The Irish symptoms can present as early as 1 week after commencement of the heart, but may take several months to appear. Hepatitis, osteomyelitis, and subcutaneous nodules are also seen in Mycobacterium avium complex reactivation. So, how to treat a case of Mycobacterium avium complex infection? MAC. MAC should be treated with three drugs known as the REA. So daily triple therapy with rifampicin, ethambutol, and azithromycin, and treatment should be continued for 15 to 18 months. This is for the Mycobacterium avium infection. And Cryptococcus neoformans reactivation may lead to symptoms of central nervous system or lung disease. And patient will come with features of photophobia, headache, neck stiffness, nausea, and vomiting.
What is the most appropriate intervention for this patient? A. Diazepam as required. B. Home oxygen. C. Morphine, PRN. D. Montelukast. And E is theophylline. A 73-year-old woman presents to the respiratory clinic for review. She has emphysema, which is being treated with glycopyrrolate, formoterol, and budesonide inhaler. She also has ischemic heart disease and hypertension. On examination, her BP is 122 by 82, pulse is 89, and arterial fibrillation. Her chest is hyperexpanded with acquired bilateral V's on auscultation. There is pitting edema of both ankles. Hemoglobin is 132, WBC 10.1, platelets 243, Sodium 143 and potassium is 4.9. Creatinine is 122. Bicarbs are 33. Atrial oxygen is 7.1. What is the most appropriate intervention for this patient?
So this is the patient with COPD, chronic obstructive pulmonary disease. So what is the cut off partial pressure of oxygen value in case of home oxygen? Anyone? It should be less than 7.2. So in case of COPD, if the partial pressure of oxygen is less than 7 point, sorry, no. So if the partial should be less than 7.3. So when the partial pressure of oxygen is less than 7.3, then we can go with the home oxygen. Home oxygen is recommended for patients with COPD who have a partial pressure of oxygen less than 7.3. In this case, irrespective of whether there is evidence of right heart failure, polycythemia, or pulmonary hypertension. So this is the isolated parameter. Once the partial pressure of oxygen falls below 7.3, go with the home oxygen, whether there is association with other things or not. In the event that any of these three factors is present, then a lower threshold of less than 8 can be considered. Where possible, oxygen should be used for 16 hours a day or longer to impact the long-term prognosis. And since this patient is suffering from the significant bilateral wheeze, the introduction of the morphine PRN will cause further reduction of the cardiorespiratory depression.
What is the most appropriate intervention for this patient's rash? A. Gluten avoidance. B. Lactose avoidance. C. Oral corticosteroids. D. Topical coal tar. E. Topical corticosteroids. A 32-year-old woman come to the dermatology clinic with an intensely itchy rash. She has previously been diagnosed with irritable bowel syndrome, having presented to her GP with intermittent diarrhea and abdominal bloating twice in the past 3 years. On examination, there are multiple papules and vesicles, predominantly over the buttocks. Her BMI is 22. Investigations are hemoglobin 102, WBC 7.1, platelets are 182, sodium 144, potassium is 3.8, creatinine is 102, and corrected calcium is 2.1. What is the most appropriate intervention for this patient's rash?
So young female patient with unexplained iron deficiency anemia and features of malabsorption. The most likely diagnosis is the celiac disease. Patient with celiac disease will also have hypocalcemia as well as hypoalbuminemia. And dermatitis seborrheicis is often associated with celiac disease, and the patient will have the multiple vesicles or multiple pruritic lesion on the extensor surface of the body. Dermatitis seborrheicis always affects the extensor surface of the body. Classical psoriasis also affects the extensor surface of the body, and the eczema or dermatitis they will affect the flexor surface of the body. So what should be the appropriate intervention in case of dermatitis seborrheicis or with celiac disease?
Gluten avoidance.
Yes, we should go with the gluten-free diet. And gluten-free diet are the rice, potato, and the wheat or maize. The pattern of this patient rash is consistent with dermatitis herpetiformis, while the mild anemia and borderline hypocalcemia are consistent with celiac disease. Gluten avoidance is the most appropriate intervention. Where the rash fails to resolve completely with gluten avoidance, Dapsone is the most appropriate next step. If Dapsone is not tolerated or is ineffective, then a course of sulfasalazine can be considered. This dapsone causes the hemolysis in a patient with G6PD deficiency. So if a patient with G6PD deficiency has the celiac disease, in that case we should go with the sulfasalazine instead of the dapsone. And lactose intolerance will come with the features of malabsorption, but this does not cause the dermatitis herpetiformis and also not the unexplained iron deficiency anemia.
What is the most appropriate treatment option for this patient? A. Compression bandaging. B. Femoral angioplasty. C. A hydrocolloid dressing. D. Surgical debridement. E. Topical fusidine. A 72-year-old man presents to the geriatric clinic for review as he has developed chronic ulceration affecting the medial side of both lower limbs over the past 6 months. He is a non-smoker and only occasionally drinks alcohol. He has type 2 diabetes for which he takes metformin. On examination, his blood pressure is 155 by 85. His ankle brachial pressure index is 0.85. A photo of his right lower limb is shown below.
So if we look at the picture here, so this ulceration, this is over the medial malleus. This is number one. This is over the medial malleus, and there has been extensive erythematous changes here, and the yellowish color pigment. This points towards the hemosiderin deposition, and hemosiderin deposition is often seen in case of venous ulcer, and ABPA greater than 7 is also excluding the arterial insufficiency. So what should be the most likely choice of treatment?
Compression bandaging.
Yes, we should go with compression bandage. The position of this patient leg ulceration coupled with extensive erythema and hemosiderosis. So this is the medial malleus. So this ulcer is over the medial malleus. There has been extensive erythema here and also the ulceration. And there is this brown pigmentation or this yellowish pigmentation is the hemosiderosis. This occurs due to the hemosiderin deposition. So we can go with compression bandage. Consistent with ulcers of venal origin, the patient ABPI of greater than 0.7, which means the triple layer compression bandaging should be considered. So when the ABPI is in between 0.5 to 0.8, then we can go with the compression bandaging. And if the ABPI is less than 0.5, this indicates the arterial insufficiency. In that case, the compression bandaging should be avoided.
What is the most likely diagnosis? A. Anderson-Fabry disease. B. Brugada syndrome. C. Congenital long QT syndrome. D. Hypertrophic obstructive cardiomyopathy. E. Transerythran amyloidosis. A 45-year-old man presents to the cardiology clinic for review. Over the past few months, he has suffered from chest pain and shortness of breath when exercising. He is a non-smoker. On examination, his blood pressure is 155 by 90, pulse is 75 and regular. He has a forceful apex beat suggestive of left ventricular hypertrophy. His chest is clear, BMI is 26. Hemoglobin is 137, WBC is 7.2, platelets 274, sodium 143, potassium 4.3, creatinine is 111. A 12-lead electrocardiogram is performed.
So this is a young patient with features of chest pain, shortness of breath while exercising, and patient also has the forceful apex beat as well as left ventricular hypertrophy. So what may be the most likely scenario from these two information? Young patient with chest pain, forceful apex beat, left ventricular hypertrophy. Think of causes of the sudden cardiac death. Which condition
Both.
can
Gum.
it? Yes,
Gum.
it can be the HCM. Now let's get back to the ECG. So look at here that the QRS, the length of the QRS is very tall. So if the QRS is very tall here, and we are getting the T inversion here, T inversion, as well as there is T inversion, significant T inversion in the V4, V5. So this tall QRS complex as well as the T inversion, they are also suggestive of the HOC. So let me show you further. So patient will have left ventricular hypertrophy with increased precordial voltage and non-specific ST segment and TF abnormalities. Deep narrow dagger like Q waves in lateral 1 AVL V5 to V6 and along the inferior 2, 3 and AVL. So you are getting the narrow dagger like Q waves in the inferior and lateral legs. And the kick and the length of the QRS should be very tall. We should get the dagger shaped TOF inversion. Here's the dagger shaped. The shortness of breath and possible myocardial ischemia seen here fits with the diagnosis of the HSM. The height of the QRS complex seen on the ECG correlates with left ventricular hypertrophy with inferior and lateral T-wave inversion is also consistent with this diagnosis. The next step in this patient management would be to conduct an echocardiogram to measure the degree of asymmetrical ventricular hypertrophy and assess any outflow tract obstruction. And the Fabry's disease or the Anderson-Fabry disease occurs due to deficiency in alpha galactosidase. Brugada syndrome will have the J point elevation greater or equal to 2 millimeter ST segment elevation in V1 to V3. Congenital long QC syndrome, they will have the prolonged QT interval.
What is the most appropriate intervention to improve this patient's liver disease? A. Gliclazide. B. Metformin. C. Is ramipril. D is semaglutide. E is sitagliptin. A 52-year-old man presented to the gastroenterology clinic for review. His GP noted abnormal liver function test and arranged an ultrasound scan and fibroscan of his liver. He is obese with impaired fasting glucose and hypertension. He is otherwise well. On examination, his PP is 149 by 84, while his pulse is 73 regular. His BMI is 35. Hemoglobin is 140, WBC is 8.1, platelets 133, sodium is 144, potassium 4.5, creatinine is 113, ALT is 95, and ALT is 95, AST is 189, and alkaline phosphatase is 148. Bilirubin is 12, and fasting glucose is 7.2. Ultrasound scan liver shows fatty infiltration, and fibroscan shows 12.1. What is the most appropriate intervention to improve this patient's liver disease?
So this patient doesn't have the history of taking significant amount of alcohol. Patient is obese, uh, and there is fatty infiltration on the ultrasound of ultrasound scan of the liver, and there is significant elevation in the transaminase, but the AST to ALT ratio is not following the greater than 2 criteria. So this is the case of non-alcoholic steatohepatitis, and NASH plus the BMI at 35 kg per meter square. What should be the most likely choice of drug? Indication for liraglutide. They are the indication for liraglutide or the semaglutide. So patient with significant obesity, BMI greater or equal to 35 kg per meter square, with or without features of non-alcoholic steatohepatitis, go with the liraglutide or semaglutide, and they are the GLP-1 agonist. This patient is obese and demonstrates fatty infiltration and increased liver stiffness consistent with the diagnosis of NASH. Semaglutide is the best option for this patient, and gastrointestinal tolerability is the main issue with glucagon like peptide 1 agonist therapy. And metformin is, in case of metformin, usually the BMI should be greater or equal to 25. Metformin can reduce this type of significant elevation in the BMI. In that case, the glutide should be indicated.
What is the most appropriate way to manage this patient's pain? A. Increase fentanyl. B. Intercostal nerve block. C. Or oral gabapentin. D. Oral naproxen. E. Top up oral morphine. A 72-year-old man is reviewed in the emergency department. He complains of severe pain over the ribs on his right upper chest. He is drowsy and experiences intermittent confusion. His current medication include regular paracetamol and a fentanyl patch at a dose of 75 microgram per hour. He wants to remain as awake as possible to say farewell to relatives. On examination, his blood pressure is 135 by 82. Pulse is 80 regular. His oxygen saturation is 91% on air. There is obvious tenderness on palpation of the upper right chest wall. His forced expiratory volume in 1 second when last measured was 30% of the predicted. Hemoglobin is 102, WBC 11.8, platelets 302, sodium 142, potassium is 4.9, and creatinine is 231. A chest X-ray is shown below.
Just the chest is showing the lung mass on the peripheral region, most likely on the hilar region. And let's come back to the scenario. So this patient is having the features of severe pain over the ribs, and patient is drowsy with intermittent confusion as well, and they are already taking the fentanyl patch. And there is also significant renal impairment here. So So what should be the most appropriate way to manage this patient pain? Can we increase fentanyl? Already we are using a high dose of fentanyl, and since the patient is drowsy and intermittent confusion, if we increase the fentanyl dose, then the patient will have significant risk of developing the respiratory depression. So we can increase the fentanyl dose. And next one is the top up oral morphine. Oral morphine is contraindicated if there is significant renal impairment. In case of mild to moderate renal impairment, usually we go with the oxycodone. And for severe renal impairment, we go with like buprenorphine or fentanyl or the alfentanyl. And here patient is having the significant renal impairment. And next one is oral naproxen. Oral naproxen is also contraindicated if there is renal impairment. Oral gabapentin or pregabalin, these are usually the choice of back in case of neuropathic pain. So we have only one option left based on the diagnosis of exclusion. We can go with intercostal nerve block. An intercostal nerve block offers a significant advantage. It can deal with the local pain affecting the upper right chest senior, which corresponds to the primary lung lesion seen on the chest section. The clinical trials of patients with terminal lung cancer and rib pain as senior, intercostal block was associated with relief of local pain in approximately 80% of patients and the reduction in analgesia in around 50%. In the event of injection of a local anesthetic is successful in relieving pain, it can be topped up later or a neurolytic agent can be considered. And increasing the fentanyl will cause a significant decrease in consciousness. Gabapentin, pregabalin, they are usually for the neuropathic pain. Naproxen is contraindicated if there is significant renal impairment as well as the morphine.
What is the most likely diagnosis? A. Acute myeloid leukemia. B. Pernicious anemia. C. Glucose 6-phosphate dehydrogenase deficiency. D. celiac disease. And E is lead poisoning. A 22-year-old man is admitted to the emergency department with severe anemia, bruising, and some bleeding around his gums. He undergoes a blood film, which is shown below.
So can you identify this? Can anyone identify this one?
Yes, these are overalls.
This is
Yes,
Philippines.
very good. This is they are the outroads. So they are the outroads, something like a crystalline, transparent like. They are the outroads. Let me show you something further. Outroads. And outroads is most commonly associated with which condition? The AML. The AML is most commonly associated with the outroads. And if we get back to the scenario, young patient with severe anemia and bleeding around the gum can also be explained with the help of acute myeloid leukemia. This patient has AML, anemia, bruising, bleeding around the gums are all key to this diagnosis. On this blood film, the narrow points towards an outward. Outwards are cytoplasmic inclusion found in myeloblasts. They are azurophilic and resemble needles, commas, diamonds, rectangles, corkscrews. They are found in AML, APML, high-grade myelodysplastic syndrome, and myeloproliferative disorder. But the most common is with the AML, followed by APML. And pernicious anemia, patient will have the vitamin B12 deficiency, and this is an autoimmune disease due to the absence of intrinsic factor of cancer. G6PD is associated with the Haines body, and celiac disease will have Howell-Jolly bodies, and lead poisoning will have Pappenheimer's body.
What is the most likely diagnosis? A. Autoimmune hepatitis. B. Cholecystitis. C. Hepatic artery thrombosis. D is primary biliary cirrhosis. And E is primary sclerosing cholangitis. A 35-year-old man presents to the gastroenterology clinic with a 4-month history of intermittent night sweats and gradual weight loss. He also has vague right upper quadrant pain. He has ulcerative colitis from 11 years, and his bowel symptoms are controlled on regular mesalazine. On examination, his temperature is 37.2, blood pressure is 110 by 80, pulse is 78 and regular. He is tender on palpation in the right upper quadrant, and you can feel a liver edge. His BMI is 22, hemoglobin is 119, WBC is 10.8, platelet is 143, sodium 144, potassium is 4.1, and creatinine is 110. ALT is 211, ALP is 372, bilirubin is 24, and PNK is positive. What is the most likely diagnosis?
So ulcerative colitis, UC is equal to PSC, and in case of PSC there will be significant elevation in transaminase as well as the P ANCA positivity. Primary sclerosing cholangitis is the most likely diagnosis here given the obstructive picture seen on the liver function test, the absence of anti-mitochondrial antibodies, and the presence of P ANCA. AMA would be positive in case of PBC, and P ANCA would be positive in PSC, and UC is equal to PSC. Ulcerative colitis is often associated with primary sclerosing cholangitis. And PSC leads to fibrosis and inflammation affecting the intrahepatic and extrahepatic bile duct. And both early PSC and PBC, if they comes up with the features of pruritus, we can go with the ursodeoxycholic acid. And autoimmune hepatitis will have the asthma antibody positivity or ANA positivity. The steroid are the mainstay of the treatment. And PBC is the AMMA disease, middle small with AMA positivity.
What is the most likely diagnosis? A. Metastatic breast cancer. B. Multiple myeloma. C. Osteomalacia. D. Osteoporosis. E. Paget's disease. A 59-year-old woman is referred to the oncology clinic with multiple joint pains, which particularly affect her left upper arm. She had a mastectomy for cancer affecting her left breast 7 years ago, followed by radiotherapy. On examination, there is some tenderness affecting her left upper arm. She has a left mastectomy scar. Her BMI is 22. Hemoglobin is 102. WBC is 6.7. Platelet is 276. Sodium 144. Potassium 4.7. Creatinine is 112. A bone scan is performed, shown below.
So this is the bone scan. So there has been increased uptake in the both shoulder region, but this is more common in the left side, as well as there is also increased uptake in the wrist region as well. And this patient also has a history of the mastectomy due to his prosperity due to breast cancer. So what may be the most likely diagnosis here? The breast cancer, in case of female, the breast cancer often metastasizes to the bone, and in case of male, the prostate cancer often metastasizes to the bone. And in case of metastatic breast cancer causing the bony infiltration, there will be increased uptake. And in case of multiple myeloma, the isotope scan should be either normal or reduced uptake. And again, in case of Pastest disease, there may be increased uptake, but in case of Pastest disease, it should not be associated with the cancerous condition. This patient will have features of significant elevation in the alkaline phosphatase, and as well as the patient will be old man bone pain with features of joint extension. So the most likely diagnosis here is the metastatic breast cancer.
Um, Dr. Hart, can you please explain the bone scan, that picture? Why is the update?
The black, can you see the black? The
Yes,
black
yeah.
here, the black here, they are the increased uptake. Anything that is
Mm.
black, they are the increased uptake. Look at here, look at the wrist region here. So there is more increased uptake in the left side, but both shoulder joint there has been increased uptake. And if we look at the
Okay.
options in and if we look at the options here, Pastest disease will have increased uptake, and the metastatic breast cancer will have increased uptake. Multiple myeloma will either have normal uptake or low uptake, and osteomalacia, osteoporosis has no association with this uptake. So look at here, the black portion indicates the increased uptake. And in case of multiple myeloma, the bone scan are often normal or may show the areas of decreased uptake. And in case of Pastest, this is associated with increased uptake on isotope bone scan, but usually presents with prominent involvement of bone joint. It is also associated with elevated alkaline phosphatase. In case of Pastest, this patient will have isolated rise in ALP, and the patient will have no features of malignancy.
What is the most likely cause of this patient's presentation? A. EPO-related hypertensive. A. EPO-related hypertensive crisis. B. Inadequate dialysis. C. Non-compliance with fluid restriction. D. Non-compliance with the BP medication. And E. Progression of renal disease. A 72-year-old man is admitted to the hospital from the renal clinic with worsening blood pressure control. He began EPO therapy for anemia related to chronic renal failure a few weeks ago. From a level of 133 by 80 uh, 6 weeks ago, his BP has now raised to 162 by 105. He complains of persistent headache. He is currently managed with hemodialysis twice a week. His BP medication has remained stable over this period. Hemoglobin is 113. 75 is 6 weeks ago. WBC is 7, platelet is 303, sodium 143, potassium is 5.1, and creatinine is 521. So this is the most likely cause of the patient's presentation.
So 6 weeks ago, the hemoglobin level was 75, and currently it is 113. And the patient has been treated with the erythropoietin therapy. So there has been very over rapid correction of the anemia due to erythropoietin induction. And also patient is having the hemodialysis. And over correction of erythropoietin is often associated with the hypertension. For this reason, patient has developed the significant hypertension. And this persistent headache is also the features of severe hypertension. So this is a case of erythropoietin related hypertensive crisis. So whenever we go with the over rapid correction of anemia with erythropoietin therapy, this often leads to the hypertensive crisis. This patient is undergoing hemodialysis and has undergone a very rapid correction of hemoglobin in response to erythropoietin therapy. The rapid rise in blood pressure without any change in medication fits with an erythropoietin related hypertensive crisis. This is thought to occur as a consequence of therapy. The erythropoietin receptors are expressed on vascular endothelial cell and smooth muscle cells, and they may facilitate a role for erythropoietin in severe signal transduction pathways. Reducing the erythropoietin dose is the most important step in the management of the condition. So, over rapid correction of anemia with erythropoietin leads to this hypertensive crisis, and reduction of the dose should be the mainstay of the treatment.
What is the most appropriate management option for this patient? A. Amiodarone. B. Bisoprolol. C. Digoxin. D. Diltiazem. E. No rate or rhythm control required. A 75-year-old woman come to the cardiology clinic for review. Her GP has requested a second opinion as the patient has developed persistent atrial fibrillation. He has a history of ischemic heart disease and stable COPD, for which he uses a salbutamol inhaler. On examination, her BP is 128 by 84, pulse is 85, BMI is 25, and she has a quiet wheeze on auscultation of the chest. Hemoglobin is 123, WBC is 74, platelet is 208. Sodium is 144, potassium is 4.7, and creatinine is 162. What is the most appropriate management option for this patient?
So this is the patient with persistent atrial fibrillation, and since the patient is old and has also association with other condition, so we need to go with the rate control. So which drug should be most appropriate for rate control?
Diltiazem, maybe? Or
Diltiazem can also be given, but usually we start with the beta blocker first.
Beta
yes,
blockers.
If
yes.
if beta blocker is contraindicated, in that case we can go with the diltiazem, but we should always start with the beta blocker. The NICE
Okay.
guideline recommends using bisoprolol for rate control in patient with atrial fibrillation, although it might be expected to worsen the lung function in patients with stable COPD. And also remember, in case of COPD as well as bronchial asthma, we can give the bisoprolol, but we can use the atenolol. There is no evidence that this occurs. As well as controlling the patient ventricular rate, bisoprolol has also been proven to reduce the major adverse cardiovascular event in patient with ischemic heart disease. And since the patient also has the ischemic heart disease, so beta blocker would be more appropriate compared to the rate limiting calcium channel blockers. Diltiazem should not be used for rate control in a patient with atrial fibrillation. Cardioselective calcium antagonists do not impact ischemic cardiovascular events that may actually worsen the symptoms of cardiac failure. Actually, in this line, they should add that diltiazem should not be used for the rate control in patient with atrial fibrillation associated with ischemic cardiovascular event.
What is the most likely diagnosis? A. Carcinoid tumor. B. Gastrinoma. C. Glucagonoma. D. Insulinoma. And E is somatostatinoma. A 45-year-old woman presents to the endocrine clinic as she has been experiencing recurrent hypoglycemia and weight gain, which has steadily worsened over the last 6 months. She recently underwent a pancreatectomy to remove a tumor within the pancreas tail since 5 days. An image from the biopsy of her tumor is shown below.
So patient is having the features of recurrent hypoglycemia and also history of the pancreatectomy. And if you look at the biopsy here, so this probably this is called the blue color. So this blue color, they are known as the glandular cell or polyglandular cell. And this orange color or the brown color, they are known as the insulin. They indicates the insulin. So most likely diagnosis here is the insulinoma. So presence of glandular cell with this type of brown color, the insulin, also features of recurrent hypoglycemia and pancreatectomy points towards the insulinoma. So what should be the most likely investigation in insulinoma?
Supervised fasting.
Yes, we should go with the 72-hour supervised prolonged fasting, and after that we should go with the measurement of the insulin and the C-peptide. So what should be the insulin and C-peptide findings in case of insulinoma? How to differentiate between sulfonylurea abuse, exogenous insulin abuse, and insulinoma? So in all the three conditions, whether there is insulin abuse or sulfonylurea abuse or insulinoma, they will have the raised insulin. And in case of insulin abuse, patient will have low C-peptide, and both sulfonylurea abuse and insulinoma will have raised C-peptide. And in order to differentiate between sulfonylurea abuse and insulinoma, we need to go with the urine test for sulfonylurea. If the test is positive, the diagnosis is sulfonylurea abuse. If the test is negative, this is a case of insulinoma. So in case of insulinoma, we'll get raised insulin, raised C-peptide with negative urine test for sulfonylurea. The histology slide shown here reveals multiple glandular cells where brown staining indicates the presence of insulin. Coupled with hypoglycemic episodes in this patient, a diagnosis of insulinoma can be made. Insulinomas are typically benign with between 5 to 30% of tumor having metastasis at the point of diagnosis. This results in hypoglycemic episodes, particularly after period of fasting, followed by period of exercise. Insulin, C-peptide, glucose testing at the time of this episode would confirm this diagnosis. So this blue color are the glandular cell, and this brown color they are the insulin. And carcinoma tumor patient will be a young patient with hemoptysis, and on bronchoscopy will get the cherry red color lesion. Gastrinoma is related to Chollinger-Ellison syndrome, which is associated with main type 1. Glucagonoma is associated with NME, nephrolytic migratory erythema, and somatostatinoma is the tumor of the delta cell within the pancreas.
What is the most likely diagnosis? A is basal cell carcinoma, B intradermal melanocytic nevus, C is malignant melanoma, D is melanoacanthoma, and E is squamous cell carcinoma. A 42-year-old woman sends a picture from her mobile phone to the local dermatology referral service. She is very concerned about an enlarged mole on her lower back. An image of the mole is shown below.
So if we look at the margin is not regular, the margin is irregular, number one, and based on the pigmentation is also not uniform here. Here is a very increased pigmentation, and there is medium pigmentation, and here is low pigmentation. So we are getting the heterogeneous pictures of pigmentation. So irregular border plus heterogeneous pigmentation most likely points towards the malignant melanoma, and malignant melanoma should be assessed using the Breslow's thickness. And if the Breslow's thickness and if the Breslow's thickness shows greater than 4 millimeter involvement, this indicates the poor prognosis, and patient should be treated with surgical excision. The irregular border of the lesion and heterogeneity of the pigmentation and rapid growth are all indicative of the underlying malignant melanoma. Urgent referral is indicated and excision should be proceeded. A lateral excision margin of at least 2 millimeters should be used with excision of the subcutaneous bed. So here we are getting irregular border of the lesion and heterogeneity of pigmentation. So the borders are irregular here, not regular, and the pigmentation are heterogeneous. They are not uniform. And in case of basal cell carcinoma, there will be pearlescent papule, and B for basal cell, B for blood vessel. So we'll get the features of telangiectasia.
What
Next.
is the most appropriate next investigation into this patient's anemia? A is colonoscopy, B is ferritin, C is percentage of hypochromic red cells, D is transferrin saturation, and E is the per GI endoscopy. A 50 years old woman is reviewed in the nephrology clinic as she is complaining of chronic tiredness, which has increased in severity over the past few months. She has CKD and no gastrointestinal symptoms. She passes small amount of urine, which her GP has tested. It does not contain any blood. On examination, her blood pressure is 121 by 81, while her pulse is 88 regular. She looks pale. Her abdomen is soft and non-tender with no masses. Hemoglobin is 93. Mean corpuscular volume is 78. WBC is 7.1. Platelet is 181. Sodium is 144. Potassium is 4.8. And creatinine is 265. What is the most appropriate next investigation into the patient?
So this patient is having the most probably the iron deficiency anemia, since the MCV is lower, and patient also has the underlying chronic kidney disease. So how to investigate a case of iron deficiency anemia in a patient with CKD? What should be the choice of investigation to rule out ID in case of CKD?
Transferrin saturation.
No, not the transparent saturation. Transparent saturation is more commonly used in case of hereditary hemochromatosis.
Percentage of hypochromic red cells?
Yes, very good. We should go with the percentage of the hypochromic red cell. We can go with the ferritin because this is the acute phase reactant protein. It is usually elevated in case of acute inflammation. So it's not a reliable marker as well. And percentage of hypochromic red cell, this is the most reliable marker to exclude iron deficiency anemia in a patient with existing CKD. The percentage of hypochromic red cell is the optimum measure for iron deficiency anemia with a level above 6%, indicating the iron deficiency anemia. The sample should be processed within 6 hours of being taken. In the event that IDA is confirmed, further investigation should be driven by the presence or absence of GI symptoms. In the event that the upper GI symptoms are present, upper GI endoscopy is a logical next step in absence of GI symptoms, progressing to colonoscopy to more appropriate. Ferritin is not recommended for the assessment of possible iron deficiency anemia in patients with renal disease. This is because ferritin is an acute phase protein and may not be entirely reflective of iron status. The percentage of hypochromic red cell is the preferred measure. Where only ferritin and transparent saturation are available, a combination measure can be used of transparent saturation less than 20% and ferritin less than 100. Due to chronic inflammation in renal disease, transparent saturation is a poor reflection of iron status when used as a single measure. It should be combined with ferritin Mrcp if transparent saturation is less than 20%.
Which of the patient's activities most increase her Barthel index score the most? Uh, A is continence apart from the occasional accident. B is dressing. B is dressing independently. C is needing help to comb her hair but otherwise able to wash herself. D is needing help to get off the toilet. And E is walking independently with the stick. A 72-year-old woman presents to the neurology clinic having suffered a left middle cerebral artery stroke 6 weeks ago. She has made a good recovery and is now walking independently with the help of a stick. She can also dress independently. She needs some help with combing her hair, but is otherwise able to wash herself. She is occasionally incontinent of urine and occasionally needs help to get off the toilet. Which of the patient's activities most increase her Barthel index score the most?
So Barthel index is for the assessment of activities of the daily living or daily life, and they are asking which of the option will have the highest point in the Barthel index. So continence apart from occasional accident, what should be the score? The score should be 2, okay? And then dressing independently will also have the 2 score. And needing help to comb her hair but otherwise able to wash herself, probably this will have the either 1 or 0 score. And needing to help to get in the toilet, this will have the score 1. And walking independently with a stick, this will have the 3 score, okay? So walking independently with a stick, this will have the 3 score. So this activities is the most increase in Barthel index. Although this patient uses a stick to walk, she is still classified as a walking independently, which scores her 3 points on the Barthel index. So walking independently is 3 score. Walking with the help of one person scores 2, while being wheelchair independent score 1. Immobility scores 0. The ranges of the Barthel score can be used to estimate whether the patient is totally dependent or totally independent or somewhere between the two. Score less than 20 indicate total dependence, whereas score above 80 should be consistent with independent living. Score of 60 to 80 indicates minimal dependence, 40 to 60 partial dependence, and score of 20 to 40 signifies patient who are very dependent. Continence apart from the occasional accident scores 2, dressing independently 2, needing help to comb her hair and otherwise able to wash herself, this is 0 score. And needing salvage to get up the toilet SSR mid range of score is 1. So walking independently has the highest score, equivalent to 3.
Which of the following results is most closely associated with poor outcome in this patient? Your answer, uh, A, ALT 1250, bilirubin 122, creatinine 132, international malaise ratio 6.6, systolic blood pressure 95. Okay. Okay. A 54-year-old man is admitted to the emergency department following a rapid deterioration in health over the past 24 hours. He is experiencing nausea, vomiting, extensive bruising, and bleeding from his gums. He admits to eating a mushroom stew made from ingredients he picked himself in the local woodlands. On examination, his blood pressure is 95 by 70, while his pulse is 100 and regular. You note extensive bruising, particularly over his arms and legs. Blood is seen around the gum margins. He is tender on palpation of the right upper quadrant. Okay. Hemoglobin is low, 88. White cell count is slightly high, 11.3. Platelet is very low, 85. Potassium, sodium is normal. Creatinine is slightly higher than normal. Corrected calcium is 2.3. Okay. Um, ALT is 1,250. Alkaline phosphatase is 297. Bilirubin is 122. Which of the following is most closely associated with poor outcome in this patient from these results? Okay. Is it alanine transaminase or
Okay,
INR?
so this patient is having the history of taking the mushroom, and mushroom contains the amantine toxin, and that toxin is a very hepatotoxic. And if you look at the liver pictures here, there is significant elevation in the transaminase levels greater than 1000, with elevation in the ALP as well as the bilirubin. So this indicates the mushroom induced. This indicates the mushroom induced acute liver failure or the non-paracetamol related liver failure. And let me show you the criteria.
Is it INR?
Yeah, this is the INR. So when the INR is greater than 6.5, whether this is related to paracetamol overdose or in case of non-paracetamol cases, the INR when this is greater than 6.5, this is an indication for the hepatic transplantation. So it will carry the poor outcome. An INR greater than 6.5 is associated with poor outcome in patient with non-paracetamol related liver failure. This is because there is a strong indicator of hepatic synthetic failure and is associated with increased risk of hemorrhage, hepatic encephalopathy, and acute kidney injury. Unfortunately, dead cup mushroom ingestion is associated with acute liver failure, and this may have been ingested following foraging. The dead cup mushroom contains alpha amantine, which is highly hepatotoxic. Alpha amantine interferes with the action of RNA polymerase. So this alpha amantine, which is hepatotoxic, and this has leads to the acute liver failure. And the INR greater than 6.5 is the indication for hepatic transplantation, and thus will carry the poorest outcome. So can you tell me the condition where the transaminase level should be greater than 1000? What are the three commonest conditions? Number one is ischemic hepatitis, number two is acute viral hepatitis, and number three is paracetamol toxicity. These three are the most common cause of transaminase elevation greater than 1000. And here in case of mushroom induced toxicity, we are also getting the transaminase level, ALT level greater than 1000. Although ALT is usually markedly elevated in both paracetamol and non-paracetamol related acute liver failure, it is not a strong indicator of prognosis. So the INR greater than 6.5 is the strongest indicator for the poorest outcome.
Okay. What is the most likely cause of this patient's anemia? autoimmune hemolytic anemia, beta thalassemia trait, bone marrow failure, glucose 6-phosphate dehydrogenase deficiency, hereditary spherocytosis. A 34-year-old man comes to the emergency department with rapidly worsening shortness of breath and lethargy. He is originally from Spain. He started a course of Dapsone a few days ago for dermatitis herpetiformis, which had not previously responded completely to gluten avoidance. On examination, he looks pale. His blood pressure is 100/70, while pulse is 95 beat per minute and regular. Investigations reveals hemoglobin is 72, elevated reticulocytosis. Direct antiglobulin test is negative. White cell count and platelet sodium all are normal. What the most likely cause of this patient's anemia? That is just G6PD anemia.
So the DAP test, the direct antiglobulin test is negative. So this is excluding the autoimmune hemolytic anemia. And if we look at the options here, only autoimmune hemolytic anemia and G6PD deficiency, these two are associated with features of hemolysis. So here we are getting the features of hemolysis. And the Dapsone is used in the management of dermatitis herpetiformis. And this Dapsone causes hemolysis in the G6PD deficiency patient. So what are the other drugs that causes G6PD deficiency patient having the features of hemolysis? Other common drugs causing hemolysis in
Sulfur
G6PD.
group antibiotics.
Yeah, sulfur groups of antibiotic as well as the ciprofloxacin and the nitrofurantoin. The key indicator that this patient is suffering from J6PD deficiency rather than autoimmune hemolytic anemia is his Mediterranean origin, good health, and bowel dermatitis. The use of Dapsone in this situation is known to precipitate acute hemolysis because it is a potent oxidizing agent. Around 400 million people worldwide are affected by J6PD deficiency, and increased rates of condition are seen in patients with Mediterranean origin. So did they mention any heritage? So the spin falls under the Mediterranean origin. And AIH will have the positive DAP test. Beta thalassemia trait will come with asymptomatic microcytic anemia. Then there should be no features of hemolysis. And in case of hereditary spherocytosis, there will be defect in the spectrin and the ankyrin defect. And this defect may lead to hemolysis, but this is not related to any drug induced.
Okay. Now, what is the most likely cause of this patient's presentation? Atrial septal defect, hypertrophic obstructive cardiomyopathy, lipomatous hypertrophy of the atrial septum, left atrial myxoma, left atrial thrombus. 71-year-old man is reviewed in the transient ischemic attack clinic, having presented to the emergency department with multiple transient ischemic attacks over the last 3 months. He is hypertensive, has atrial fibrillation, and has previous inferior myocardial infarction several years ago. On examination, his blood pressure is 148/88, while his pulse is 88 per minute. An echocardiogram is shown below.
So this is the echocardiography picture. So can you diagnose seeing the picture?
I don't know if it is myxoma or not.
Okay. Let me show you. So in the echocardiography, this is the right ventricle. This is the aorta. This is the left ventricle. And this is the left atrium. So look at him. So this is the left atrium, and this mass, this homogeneous opacity, whitish color, this is the left atrial myxoma. So this is the left atrial myxoma. This is the right ventricle. This is the aorta, and this is the left atrium, and this is the left atrial myxoma. And patient with left axial myxoma often comes up with features of multiple transient ischemic attack as well as the atrial fibrillation. There is a mass in the left atrium seen on the echo consistent with the left atrial myxoma. The irregular echogenicity pattern within the lesion is consistent with intracardiac tumor. So the echogenicity here, this is not homogeneous. This is actually inhomogeneous. There has been irregularity in the echogenicity, and this is the left atrium. Most intracardiac tumors are excised because even with anticoagulation and rate control, the risk of further transient ischemic attack cannot be completely controlled. Okay, next one.
Okay, which of the following is most associated with a poor prognosis in this patient? Increased beta-2 microglobulin, increased protein tyrosine kinase expression, male sex, nodular pattern of lymphocyte infiltration on bone marrow biopsy, normal thymidine kinase level. Poor prognosis. Okay. A 64-year-old man present to the hematology clinic for review. He has experienced 2 episodes of shingles over the past 6 months and has developed progressive tiredness, lethargy, and abdominal fullness. On examination, his abdomen is soft, although there is marked splenomegaly and palpation. Hemoglobin is 91. White cell count is markedly elevated, 32.1. Platelet is low, 122. Other are normal. Okay. What is the
So
where is the prognosis?
this is the old age patient with marked splenomegaly having features of anemia, thrombocytopenia, and white cell count is significantly elevated with features of lymphocytes. So what may be the most likely diagnosis here?
CLL.
Yes, very good. So
Chronic
this is the case of So in case of CLL, there will be predominant lymphocyte, and often this is associated with splenomegaly. And in case of CLL, the poor prognosis is the increased beta-2 microglobulin. So this is the scenario of a CLL, chronic lymphocytic leukemia, with significant elevation in the lymphocytosis as well as marked splenomegaly in the presence of anemia and thrombocytopenia, and the increased beta-2 microglobulin. This is associated with poor prognosis. Beta-2 microglobulin levels are closely correlated with disease stage and tumor burden in chronic lymphocytic leukemia. Beta-2 microglobulin levels also rise in patients with impaired renal function, which is poor prognostic indicator. Levels greater than 3.5 milligram per liter are considered the cutoff for poor outcome. Other markers include elevated thymidine kinase greater than 10 unit per liter and deletion of the 17p. And deletion of the 13q, 13 is known as the unlucky number. So deletion of 13q is associated with good prognosis, and deletion of 17p is associated with poor prognosis.
What is the most appropriate intervention for this patient? Start dapagliflozin or start ferrous sulfate, stop bendamide, stop ramipril, undergo aortic valvotomy. Okay. A 75-year-old man presents to the geriatric medicine clinic as he has fallen over twice in the past few weeks. He has had 2 previous episodes of myocardial infarction, and he has history of hypertension for which he takes 10 milligram ramipril and 2.5 milligram indapamide each day. He also has type 2 diabetes for which he takes 1 gram metformin twice a day. On examination, his blood pressure is 140 by 90, but when supine, this falls to 115 by 80 when measured immediately on standing. Okay, and is maintained after 5 minutes. His pulse is 72. He has an ejection systolic murmur loudest in the aortic area, which does not radiate to the carotids. Investigations are all normal. Okay, hemoglobin is okay. Just glucose is slightly higher level.
So this is the patient with hypertension with along with the myocardial infarction, and the patient is taking the AC inhibitor, thiazide like diuretics, and also taking the metformin. And this patient has the significant postural hypotension. So which drug should be avoided in case of postural hypotension? Can anyone tell me which drug should be avoided in case of postural hypotension?
Diuretics or ramipril?
Diuretics.
So the thiazide like diuretics often causes the postural hypotension. So the indipamide is a thiazide like diuretic, so it should be avoided in case of postural hypotension. Just remember that thiazide like diuretic should be avoided in case of postural hypotension. Thiazide like diuretics such as indipamide may cause postural hypertension, and indipamide should be discontinued. Measurement of postural BP should be repeated a few days after indipamide is stopped. Given the angiotensin converting enzyme inhibitor have proven outcome benefits in type 2 diabetes, remifri should be continued if possible. So the AC inhibitor can also cause the postural hypertension, but since the patient is diabetic, so we need to go with the either AC inhibitor or ARBs. So it's better to stop the indipamide compared to the remifri.
What's the most likely diagnosis? Basal cell carcinoma, cutaneous leishmaniasis, cutaneous sarcoidosis, libromatous leprosy, venous ulcer. 21-year-old man present to the infectious disease clinic with an ulcer on the medial side of his ankle. He is originally from Colombia. The ulcer began as an erythematous plaque and gradually developed into a more significant size. It is painless. An image is shown.
So this patient has ulcer on the medial side of his ankle and has come up with the painless erythematous plaque. And if we look at the option, this is situated in the superficial regions, and the age is everted, or the age is slightly raised, and there is pus formation. So what may be the most likely diagnosis based on the options?
Leishmaniasis.
Yes, very good. This is the case of cutaneous leishmaniasis. So look at here, the location would be superficial, the age would be raised, and there should be pus formation. So all the lesions should be superficial, age should be raised, and there should be pus formation. So can you tell me the choice of treatment in case of cutaneous leishmaniasis? First line choice of drug?
Sodium stevogluconate.
Actually, sodium stibogluconate is the it sodium stibogluconate is used for the parenteral purposes. Usually we go with the oral miltefosine.
Doxycycline.
No, oral miltefosine. Doxycycline can also be given, but usually we go with the oral miltefosine.
Okay.
Over the 2/3 cases of cutaneous leishmaniasis are found in just two countries: Afghanistan, Algeria, Brazil, Colombia, Iran, and Syria. Cutaneous leishmaniasis begins as an area of erythema, which later breaks down to form an ulcer with raised edge. So the edge or the margin should be elevated or raised, and there should be pus formation, and the location should be the superficial portion. Cutaneous leishmaniasis begins as an erythema, which later breaks down to form ulcer with raised edge and evidence of pus. So oral miltefosine. Miltefosine is the oral drug, or this is the miltefosine is now the preferred choice of treatment option for all forms of the condition. And parenteral agents for treatment of CL includes the pentavalent antimonial like sodium stipogluconate, amphotericin P, and pentamidine. They are usually the injectable or the intramuscular drug. For this reason, they are usually reserved for the second line drug. And the first line is the oral miltefosine, and second line is liposomal amphotericin P, sodium stipogluconate, and the pentamidine. And in case of basal cell carcinoma, the patient will have the pearlescent papule, and B for basal, B for blood vessels. So basal cell carcinoma will have the telangiectasia. And in case of lymphomatous leprosy, there should be hyperpigmentation with decreased sensation. And venous ulcer will occur over the medial malleolus, and there should be hemocyanin deposition leading to yellowish color, and there should be extensive erythema.
What's the most likely cause of the rash seen in this patient? Dermatitis herpetiform, erythema multiforme, erythema nodosum, gouty psoriasis, Kaposi sarcoma. Kaposi. 45-year-old woman present to the dermatology clinic with a rash which is more apparent over the lower limb and which has increased severity over the past 8 weeks. She is known to have abused heroin in the past and is an alcoholic. On examination, she has signs of chronic liver disease with palpable liver edge and pitting edema of both lower limb. Her body mass index is 21. The rash shown below is seen, and there are additional lesions within her mouth. Okay. Seems Kabusi.
So this is the patient with heroin abusers, and heroin abusers are often associated with the HIV, and the commonest dermatological malignancy in case of HIV is the Kaposi sarcoma. And in case of Kaposi sarcoma, we'll get the erythematous papules. These are the papules. Only the color changes, no elevation, and they are the elevation along with color change. They are the erythematous nodules, and they are the erythematous papules. And combination of erythematous nodules and papules in a patient with HIV, the most likely diagnosis is the Kaposi sarcoma. And in case of dermatitis herpetiformis, we'll get the intensely pruritic vesicles in the extensor surface of the body. Erythema multiforme will come with target lesion. Erythema nodosum will come with the shin lesion. And in case of gutted psoriasis, usually we get the raindrop pigmentation or the teardrop pigmentation following the upper respiratory tract infection. These erythematous nodules and papules are consistent with Kaposi sarcoma, while the previous heroin abuse raises the possibility that this patient has the HIV positive. And the HIV test is the next step in this patient management, while initiation of the ART can slow the progression of the lesion. In patient with widespread lesions, systemic therapy with interferon alpha may help to drive the clearance. And the human herpes virus 8, this is responsible for formation of the Kaposi sarcoma. The 8 almost looks like K, so Kaposi sarcoma occurs due to human herpes virus 8. Dermatitis herpetiformis, this is associated with the celiac disease, and gluten, and often is associated with gluten sensitivity. So gluten-free diet is the choice of treatment, and patient will come with intensely itchy rash on the extensor surface of the body, like in the buttocks, in the back, or in the both thigh. Multiforme will come with the target lesion, and herpes simplex virus infection is the most common cause of erythema multiforme, followed by mycoplasma. Erythema nodosum will come with the shin lesion, and gutted psoriasis will have the raindrop pigmentation or the teardrop pigmentation following the respiratory tract infection.
What's the most appropriate treatment for this patient's thyroid disease? Carbimazole, propyl thiouracil, carbimazole antiroxin, partial thyroidectomy, symptomatic treatment only. A 28-year-old woman comes to the endocrinology clinic having suffered from flu-like symptoms for the past 2 to 3 weeks. She describes pain over the thyroid gland and frequent palpitations. She is 30 weeks pregnant with her first child. On examination, her blood pressure is 102 by 85. Her pulse is 105 and regular at rest, and she has a fine tremor. The thyroid is tender on palpation. Hemoglobin is low. White cell count is normal. Platelet normal. Just thyroid stimulating hormone is very low. Okay. Free thyroxine is 29. Okay. What the treatment for this patient disease?
So this patient has comes up with the features of
Decurvan.
hyperthyroidism, and since there is a history
Mhm.
of flu-like symptoms with pain over the thyroid gland, so most likely this is the case of subacute thyroiditis, also
Subacute
known as the
thyroid.
dequervous thyroiditis, and choice
Curve.
of treatment is the symptomatic treatment. This patient has subacute thyroiditis evidenced by mild thyrotoxicosis, tender thyroid gland, and flu-like symptoms. The symptoms typically resolve over a period of a few weeks. When a patient demonstrates severe symptoms, beta blocker are the one potential treatment, although their use can lead to intrauterine growth restriction. And in case of Graves' disease, along with pregnancy, in the first trimester, we should go with the propylthiouracil, and in the second and third trimester, choice of drug should be carbimazole, because when propylthiouracil is used in the later phase of the pregnancy, they are associated with maternal hepatotoxicity. So first trimester, go with propylthiouracil. Second and third trimester with Graves' disease, go with carbimazole.
What is the most appropriate next intervention in this patient? Dopamine, furosemide, spironolactone, terlibrine, transregular intrahepatic portosystemic shunt. 48-year-old man is reviewed in the hepatology board. He has been admitted for treatment of spontaneous bacterial peritonitis. He has alcoholic cirrhosis. His diuretics were discontinued due to hypotension. A rise in his serum creatinine has occurred despite volume expansion with albumin infusion. On examination, his apyrexial, his blood pressure is 114 by 80, while his pulse is 82 and regular. He has marked ascites, although his abdominal tenderness has resolved since admission. Hemoglobin is 108, white cell count normal, platelet is very low, 59, sodium is low, 131, potassium normal, creatinine is double normal, CD-active protein is slightly high, 67. Albumin is 26, it's very low.
So
So
this
what is the next intervention for this patient?
So this was a patient with spontaneous bacterial peritonitis along with alcoholic cirrhosis, and the patient now has developed a renal impairment. So this is a case of hepatorenal syndrome, hepatic involvement plus renal involvement, hepatorenal syndrome. So is it type 1 or type 2?
According to the duration,
So So the type 1 ASRS, it will be rapidly progressive, and there will be doubling of the serum creatinine to greater than 221 micromole per liter, or halving of the creatinine clearance to less than 20 ml per minute over a period less than 2 weeks. So that if the duration is less than 2 weeks and there is doubling of the serum creatinine, so there is doubling of the serum creatinine, and the duration here is how many days? As they mentioned regarding the duration. They have not mentioned the duration, but just looking at the doubling of the creatinine, and most likely this patient also had a very short duration, less than 2 months. So we can assume that this is the case of HRS type 1. So what should be the most appropriate next intervention in HRS type 1? Choice of treatment of hepatorenal syndrome. Anyone?
Calipressin.
Yes, very good. We should
that's
go with the Charlie Pressin. This patient is suffering from the hepatorenal syndrome type 1 resulting from spontaneous episodes of bacterial peritonitis. The criteria for this diagnosis are summarized below. Cirrhosis with ascites, serum creatinine 133 micromole per liter, absence of hypovolemia as defined by no sustained improvement of renal function, creatinine decreasing to less than 133 micromole per liter, following at least 2 days of diuretic withdrawal if on diuretics, and volume expansion with albumin at 1 gram per kg per day up to a maximum of 100 gram per day. No current or recent treatment with nephrotoxic drug. Absence of parenchymal renal disease as defined by proteinuria less than 0.5 gram per day. No microhematuria less than 50 red cells per high powered field and normal renal ultrasonography. In HLS type 1, a doubling of the serum creatinine greater than 221 micromole within 2 weeks will occur. And terlipressin. Terlipressin is the somatostatin analog. This causes the splanchnic vasoconstriction, and ultimately there would be more and more blood supply to the kidney, leading to renal perfusion. For this reason, the terlipressin is the first line choice of drug in case of hepatorenal syndrome. And if the patient does not respond to terlipressin, then in that case we can go with the TIPS, transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portosystemic shunt is reserved as an option for patients with HRS who fail to respond to the medical therapy.
What is the most appropriate treatment for this patient? Chlorpromazine, clozapine, diazepam, haloperidol, risperidone. 75-year-old man present to the Parkinson clinic for review. He has suffered from Parkinson's disease for 7 years and takes multiple medications. While there is no sign of tremor, he appears bradykinetic with an apraxic gait and an absence of any dyskinesias. His wife particularly concerned as he has become distressed at night over the past few months. He has been suffering from visual hallucinations and believed that people are constantly talking about him at the end of the bed. These symptoms have been unresponsive to uh, quetiapine, and his behavior at night is now unmanageable despite changes to his care package. His physical examination consistent with advanced Parkinson's disease, while his mini mental state examination is 27 by 30.
So this is a patient with advanced
Short
Parkinson's
impression.
disease along with features of visual hallucination. So most likely this is a case of Lewy body dementia or the Parkinson plus syndrome coming up with the neuropsychiatric features. And we know that the dopamine antagonist drug like the risperidone, haloperidol, and the chlorpromazine they causes the dopamine antagonism, and they should be avoided in a patient with Parkinson's disease. And if a Parkinson's disease comes up with the features of neuropsychiatric features, then the most likely choice of treatment would be the low dose short acting benzodiazepine. But diazepam is the long acting benzodiazepine, so we can also use the diazepam. And among the atypical antipsychotics, we can either go with the quetiapine or the clozapine. And quetiapine is usually preferred compared to clozapine because clozapine causes the neutropenia. But since the quetiapine isn't in the option, so we can only choose the clozapine. This patient is experiencing psychiatric manifestation of Parkinson disease and medication. This includes hallucination and resulting behavioral changes. The first line management include reviewing the home setup, ensuring that no intercurrent illness. If over-treatment with dopamine is suspected, dopaminergic medication should be reduced. The patient condition may benefit from an increase rather than decrease of such medication. However, this may worsen the neuropsychiatric symptoms. As such, treatment is required for this to allow for future titration. Clozapine has proven efficacy in the management of psychosis associated with Parkinson's disease. It has only weak dopamine receptor blocking activity at the D1, D2, D3, and D5 receptor, but shows high potency for the D4 receptor. Clozapine has potent anti-alpha adrenergic, anticholinergic, antihistaminergic, and arousal reaction inhibiting effects. It has also been shown to possess the anti-serotonergic properties. This multipotent effect may account for why it has better tolerability compared to other antipsychotics. The usual dose of clozapine is 6.25 milligram before sleep, while the typical dose of clozapine in Parkinson's disease is in between 12.5 and 50 milligram per day. Out of two intervention studies, one showed a minor worsening of the motor symptom, while the other showed a small improvement. The overall consensus is that there is no overall change in motor function associated with clozapine use. Granulocytopenia is the most common severe adverse effect occurring in up to 2% of patients. Therefore, frequent monitoring of the patient full blood count is mandatory. For this reason, the first-line treatment for psychiatric manifestation of Parkinson's disease is a trial of quetiapine. This quetiapine does not cause the neutropenia or granulocytopenia. For this reason, quetiapine is often preferred compared to the clozapine.
What's the most likely cause of this patient's blood picture? Acute pancreatitis, hyperosmolar non-ketotic state, lactic acidosis, non-compliance with diabetes therapy, uh, normoglycemic ketoacidosis. 67-year-old man present to the emergency department having experienced vomiting and dehydration. Over the past 48 hours, he has a respiratory tract infection. He takes metformin and ganagliflozin to treat his diabetes. He commenced ganagliflozin 2 months ago. On examination, his temperature is 37.8. His pulse is 89 and regular, while his blood pressure is 100 by 70. There is crackles at the right base on the auscultation. His abdomen soft but mildly tender due to vomiting. His body mass index is 23. From the investigation, sodium is slightly on the upper limit, potassium slightly on the lower limit. Bicarbonate is chloride is high, a higher limit, higher normal. Glucose is high, 12.2. Chloride. Bicarb is very low, 14.
So calculate the anion gap from here. Positive ion minus negative ion. So 144 plus 4 is equal to 148 minus 120. So this indicates the raised anion gap. And also the low bicarbonate points towards the metabolic acidosis. So this is a case of raised anion gap metabolic acidosis. And the glucose level is almost within the upper limit of the normal range. So this ketoacidosis, this normoglycemic ketoacidosis will come up with the features of raised anion gap metabolic acidosis. And as well as we know that the glyphosate, the SGLT2 inhibitors are often associated with the normoglycemic ketoacidosis. So what are the other side effects of SGLT2 inhibitor? So SGLT2 inhibitor causes normoglycemic ketoacidosis, and they causes total cholesterol elevation, HDL and LDL. SGLT2 inhibitors work by reducing glucose reabsorption in the proximal convoluted tubule, increasing urinary excretion of glucose. Important as is the cause of main side effect, increasing urine output, weight loss, and UTI, and they will cause the normoglycemic ketoacidosis. So this is indicating the normoglycemia, and the raised anion gap metabolic acidosis points towards the ketoacidosis. So this is the case of normoglycemic ketoacidosis. Normoglycemic ketoacidosis is a recognized phenomenon across the class of SGLT2 inhibitor used to treat type 2 diabetes. It is more likely to be seen in patients prescribed test drugs for type 1 diabetes, severely limiting their use in this situation. Patient present with typical symptoms of ketoacidosis, although as their blood glucose may not be particularly elevated. Ketoacidosis is consistent with the raised anion gap, so positive ion minus negative ion, and occurs primarily in patients with incipient beta cell failure who have long-standing type 2 diabetes. Okay, probably this is the last question. Okay, go on.
Okay, what's the most appropriate next step in this patient's management? Apixaban, low molecular weight heparin, and then rivaroxaban, low molecular weight heparin, followed by warfarin, or low molecular weight heparin over 3 months, warfarin. 27-year-old man presents to the emergency department with a swelling above his left knee. He has discharged from hospital 3 days ago following arthroscopy of his left knee due to cartilage tear. A venogram reveals deep vein thrombosis above the knee. What's the most appropriate next management for this patient?
So this is a patient with deep vein thrombosis. So what should be the first line choice of drug in case of DVT? The directly oral acting anticoagulant like the factor 10A inhibitor, they are the default or first line choice of treatment in all cases of deep vein thrombosis. There is only two exceptions. Number one is in case of pregnancy, we use the low molecular weight heparin, and number two is the in case of a significant renal impairment, we go with the warfarin. But here the patient is not the patient is a male patient, so there is no question of being pregnant and there is no renal impairment here. So the default choice of treatment should be the factor 10A inhibitor like the directly oral acting anticoagulant, like the apixaban or the edoxaban. This patient has developed a provocatively. So what should be the duration of apixaban in this patient? 3 months or 6 months? Is this provoked or unprovoked?
It's
Provoked.
Yes, this is
provoked
provoked.
3 months.
So we should go with the 3-month anticoagulation. This patient has developed a provoked DVT as a result of left knee surgery. According to the NICE guideline, provoked DVT don't require thrombophilia testing. DVTs can be managed with apixaban or rivaroxaban from the start. There is no need to step through low molecular weight heparin. Low molecular weight heparin is only indicated if this is associated with pregnancy. Apixaban is a highly selective oral factor 10A inhibitor which does not require monitoring of the INR. This gives a significant advantage over warfarin. Treatment should be considered for 3 months. Since this is provoked, we should go for 3 months. And in case of unprovoked, as well as if there is underlying malignancy, duration should be at least 6 months. So we have completed our October 2020 diet. So thank you everyone.
Thank you, Dr. Hat.
Okay.